What's at the end of the rainbow?
Hi, how are you?
But they never called me.
You're looking at like
I think that was probably a way to, and it made me feel more at ease.
Appreciate it. Welcome back.
Through the years.
Yeah, that's man. I think I was one of my special artists.
I know, like I
Whenever you want. We've got a few more videos. Hey Mike, how are you?
How are you doing?
Doing well. Got a little bit of a form here. Yeah, looks like
Look, I got to do well, they
like data.
yeah. So Susan, how many people are registered?
I just walked by the front. I would say it looks like probably close to 40 is registered. Good morning. How are you?
Good.
Yeah.
Thank you. Yeah.
Hey, how you doing, Scott? Are you happy?
Yeah, I'm trying to get there. We'll see.
Joy's free, right? You're on the right path.
Thanks, Ted. We'll go ahead and get started in about 1 minute. So.
David, I moved your coffee.
So he has a pointer.
Has what?
Are you going to use that? Let me turn it on.
What do you want me to?
It's up to you. Whatever you want.
I kind of got a big mouth.
Okay. If you
How about that try it?
Okay. All right.
Maybe I'll try that.
I want to welcome you all to the Mid-America Regional Council. I'm Scott Lakin. I direct the Regional Healthcare Initiative here at MARC. And we do have a number of people caught in traffic. And there are some traffic issues, so we might have some more people filter in as we get started. Before I introduce Susan, I want to introduce two other people. Ashley Beek is on the Regional Healthcare Initiative staff. She's in the back there. She's the new health planner here at MARC and has done a lot of work on this forum, as I've got her working on a lot of other things as well. And then Tracy Garcia-Castells, who is popping in and out and is a little shy, I think. She also did a lot of work on this. So when you get a chance during the break, you might talk to them and thank them on that. And you know, we're glad you're here. This is a forum on integration. We're looking at improving the quality of health care to the patients. And we are having a series of these. This is the kickoff, and we're having a series every other month. And you should be getting information on the next one in June as well. But they're going to be on different topics. They're tailored to what your needs are. The next one in June will be on the financial aspects of integration. So you might want to look and see which ones that you'd like to come to, hopefully all of them. I also want to thank the REACH Foundation. They've been very helpful, and this forum is paid for by the gracious graciousness of the REACH Foundation, and we always appreciate that as well. And so, again, welcome. Without further ado, I'll introduce Susan Crane-Lewis, who's the Kansas co-chair of the Metropolitan Mental Health Stakeholders Group. We meet, I believe, the third Thursday of every month, and those of you that want to attend those meetings are welcome to come to those as well. So, Susan?
Thank you.
I would just start by thanking Mark for hosting this, and also for hosting and staffing the Metropolitan Mental Health Stakeholders Group. As a mental health advocate, I end up involved in all kinds of different coalitions and collaborations. This one is particularly interesting to me. It's categorically different than many that I've been involved in over my 15 years. And according to David, it's categorically different than many coalitions and collaborations that operate throughout the United States. The Metropolitan Mental Health Stakeholders endeavors to serve both as a synergistic and a catalytic force that combines all of the elements, or I guess all of the silos around mental health. So we're talking about folks with mental illness, we're talking about folks with cognitive, intellectual, developmental disabilities, and we are talking about folks with substance abuse. And most of us in this room realize that is often the same person trying to get between silos. But we are looking at the broad spectrum of what is considered mental health, and how that is funded, and how good best practices programming happens. The other thing that's categorically different about this group is that, unlike many, we have chosen to really sink our teeth into and wrap our arms around a topic or an issue. Study it if we need, do research on it if we need, pull together all of the best information so that folks on both sides of the state line can move forward to solving the problem. And then our group steps back and is available for consultation and monitoring. The analogy I've used is, it's kind of like we get the kid raised up, we get them through high school, we get them through prom, we send them off to college. For a little while, we are happy to have them come back every weekend, and we'll even do laundry. But eventually they need to get out and move on, because we got other kids to raise. And so, unlike many organizations, collaborations I'm with, this one does not keep on keeping on the same thing over and over. That said, we are, with the issue of behavioral and physical health integration, we are now, I would say, probably, David, your prom. We've got our kid in prom. We've done the research. The forums that are coming up are about some of the very specific information that our community has found that it needs to make integration work here in Kansas City. It's driven by the research we conducted last year. We are incredibly pleased to be able to start off with, I guess, a 20,000-foot and a very broad perspective from David Swann. David is got a whole lot of initials behind his name. He's the Senior Healthcare Integration Consultant for MTM Services. I've had the great and distinct pleasure of visiting with David this morning and finding out that the world is indeed very small. Not only does David now hail from the same area that my mother relocated to, but David was raised in the town that my mother had lived in before. He's a terrific guy. He is absolutely brilliant, and is going to kick us off with some of the broader perspective that's going to guide some of our efforts. David, welcome. I'm so glad you're here in Kansas City.
Thank you, Susan. Appreciate that so much. Coming out of the closet over here, kind of in the corner. So it's wonderful to see you, and what an honor it is to be selected to help you launch this first of the series of these. So I consider it a great pleasure and honor to be here. I have been working in and around Kansas City now for several years, doing the same kind of integrated work. That's why maybe we moved to the prom. So this is not junior high school, but we're sort of getting on with this. There's a lot of progress being made across your area. So I'm just thrilled that we could be a part of it. So a couple other things that might help you maybe understand from where I come from, and maybe would help you to identify with certain questions you might want to ask me. And I really do want this to be a dialogue. I do have a presentation, but we've got the whole morning. I intentionally shortened the presentation so that we would have time for a lot of Q&A. What I want to do is I want to leave you with a lot of information that you can use to go out into your communities and make change happen around integrated healthcare. So thinking about maybe what I bring to this, this is my 31st year of professional work. And I've been running a community mental health center in the state of North Carolina for all of that 30 years. And it's 5 or 6 years ago, we converted that mental health program to a managed behavioral health organization. So for those of you who are from the Kansas side, you would actually know us whenever you look at your private managed behavioral health organizations, those big three. I know Optum, Simpatico, and there's one other out there. We are doing that in a public sector arrangement and at a region in North Carolina. 8 counties in one large region, about 1 million covered lives, about 160,000 Medicaid covered lives. And of the Medicaid, it is a prepaid inpatient health plan under the section 1915B of the Social Security Act that allows us to manage Medicaid in a capitated environment. So in other words, I'm at full risk with the Medicaid population. I get that money in 1/12 intervals every month, and we make it work. And we are accountable for all of the care that the Medicaid eligibles need. So it's an incredible opportunity to go from a community mental health provider historically to now a managed behavioral health organization. So that's a little bit about my background and my day job doing that, and I do the consulting kind of on the side. But my specialty has been about integrated healthcare because I got started doing that in the 80s when we didn't know what to do about some of these problems and challenges about no-shows and about how to make care better. So we tried different things, and one of those was integrated healthcare. It was 1987 when I first started doing it, and it was focused around pediatrics and children with mental health needs. And what we saw is we saw some better care come about as a result of that, and we also saw a reduction in the no-shows, and we saw an increase in the adherence to mental health treatment. So all of those started to shape what we did over the years, and now here we are, many years later, decades later, doing some very great integrated care across the nation in a lot of places. And there's a lot going on, of course, in both Kansas and Missouri, and particularly around the Kansas City area. So thanks again for having me. Can everybody hear me okay without a microphone? Usually, Scott has said I have a big mouth. So, I thought that was a compliment, but I wasn't sure. So knowing that maybe, if I don't have to use a mic, that was a compliment.
David, we do have someone on the phone, so we might want to, Rebecca, can you hear okay?
Scott, I can hear you very well. David, you sound a little bit far away, but I'm okay.
Maybe I should use that microphone then. I'll do that, and then we will, I think I might have turned it on. Test. Where's Tracy when you need?
Yeah. I've said that many times.
All right, I think I figured it out. What was the lady's name on the telephone? Do you remember? Test, there it is, right there. Testing, all right. How about this for a microphone? Can you now hear us on the phone?
That's good.
Okay, perfect. Thank you for making that comment. I appreciate Scott letting me know about it so that I wouldn't forget it. And I'll hook this all up, and then we'll be good to go. All right. Very good. Well, thank you again. At the bottom of all of this for integrated healthcare, there's got to be a common goal. And I want to try to give you a common goal, a common theme, something that you would hang on to about why you would do something like this. In other words, what's your business case? What is your challenge? Why would you want to do something like this? And why would you want to promote it? And I say it's all about better care. That's got to be what we're all about. It's what I live and breathe every day, both in my day job and in my consulting work. It's about better care. We're trying to do something better for the population that we're responsible for, or that the population that we are accountable for. So it's about consumers and their better care. How do providers deliver better care? For managed care organizations, and I've already shared with you now that I can wear that hat as well too. So when I'm managing care, it's all about better care. Because, and just to understand that real clearly, because I know managed care sometimes gets a bad rap. In fact, a lot of my colleagues said I crossed over to the dark side when I did that, several years ago. Well, for managed care organizations, I am accountable for a Medicaid person out on the street today that's not receiving any care at all. And providers don't often think about that. They think they're accountable for the people that are in their building, that are in their offices, that are asking for help, or that are sent by somebody to get some help. But there are people out in our community that are not getting the kind of help that they need. And I am accountable for them at a managed care level. So my provider network and your provider networks need to join with managed care to be just as accountable as the payers are. Sometimes payers just don't act as if they're that accountable, and that's the thing that I want to try to change. Government payers, a lot of the drivers here are Medicaid and Medicare. You will see that the big payers are the ones that are driving a lot of healthcare integration efforts because of the outcomes that come from that. And then you see accrediting organizations. Accrediting organizations are also trying to help programs achieve better care. And as a result, they are now having credentialing and different kinds of accreditation standards for integrated healthcare that makes sense for people as well. So why integrated care again? And I think, and yesterday, some of you were with me yesterday, and some of you were with me the day before yesterday. And I appreciate your willingness to come back. I've got to meet old friends, new friends here. It's been great. These are the big three. And I'd like for you to commit this to memory. If you could think about what these opportunities are about to improve access, to improve the care, and we cannot forget to have a potential cost reduction. And you may know this if you follow the Center for Medicaid and Medicare Services, you may know this as the AAA. This is bending the cost curve while providing better care. So, in other words, an example of that would be that if we delay care for the person out here in Kansas City today, what might happen to that person if we delay care, if we keep them away? This is now the audience participation time. So if we delay care to someone and say, you can't get in, or we're not going to remove barriers for you to get in, where might they likely show up? The emergency room, exactly. And is that the best place for the care?
No.
And is that the least cost for the care?
No.
Absolutely. And are we going to, and do we generally get good outcomes for mental health patients when they go to the emergency room?
Only to stabilize.
Absolutely. Only stabilization, and that's about where it goes. This guy gets the star for the day. He's the teacher's pet. So, so all of that is what this is about. Again, that's just an example of how that that access has to come, improved care has to come for that, and then we're going to be bending this cost curve. We're going to start to provide treatment that is lower cost in the long run. Sometimes, though, it may spike, and you'll see. In fact, I think I've got some slides here. You will see a spike in some of the costs when you initially turn this thing around. Just because people are now increasing access and there's more people getting care. But over the period of time, what you'll see is that people will get more appropriate care, and therefore it will actually cost less as time goes on. So that's the justification. If you're looking for the business case, this is it. Bottom line, three big things that are great outcomes. So don't forget those. It's in your handout. Very important. So why have we been doing this? Well, it's all under this rubric of healthcare reform, and there's a lot to say about healthcare reform, and I'm not talking the politics of it. I'm talking really about the operations or the mechanics of healthcare reform, and what does it mean? So we've got parity and national healthcare reform, and as they're being implemented, we're going to see more people Now, and I know there's, the different states are adopting different parts of the Affordable Care Act, but generally, more people are going to have access. Back to that first item of the triple aim, more people will have access over a period of time to proper health care opportunities. So maybe it's through health insurance exchanges, maybe it's eventually Medicaid expansions, although, there's a number of states who have said, no, we're not going to do that. But I think over a period of time, we're still going to see increased potential because the logic seems to defy why people would resist it. The logic would say, if we increase the access, if we get people the care they need early on, then what will happen later on is they will have had better care and more appropriate care. Back in the 80s, I used an analogy that I don't use that often, but I'm just thinking about it right now because it seems so simple. And I said, what I felt like I was doing in the late 1980s was that I had a big mental health center, and we had some space up above the falls, and we had a place down below the falls. And we invested resources. When people got over, we were bandaging them up and picking them up and putting them back together. And also, we had the mental health system up above the falls, and we had a bunch of rope and inner tubes, and we were yanking people out before they got over. That's essentially what I was trying to do, was to keep it all going. Obviously, we had to have some below, we had to have some above. And what's happened over a period of time is that the resources have been shifted to below the falls, probably in most of our states and in most of our activities. So now, just as this nice gentleman said, a lot of services are being delivered in emergency rooms, but not a lot of benefit comes from that. A lot of services are being delivered in crisis-natured service arrays, but yet what we're doing is we're getting people out of crisis. But what about the prevention? What about the early intervention for that crisis? If people had the right care at the right time, would they still go over the falls? Some would, obviously, but we could probably get some out and probably hold some people back. So national health reform is helping us to do that, to get earlier on care for people so they can have access to treatment and addiction for mental health and addiction services through some kind of expanded insurance coverage or some type of expansion of the payment system. Specialty behavioral health care organizations now have to expand their capacity because of item number 1. So this is scary for providers, and I know some of you in here are provider organizations or represent provider organizations, and if you are, you're going to know some people that are in that particular area of their work. Well, what's scary to those groups is now they're going to have to open their capacity or expand their capacity to serve more people. And they've got fixed budgets, they've got fixed building spaces, they've got fixed numbers of staff members, and they're all questioning, how do they do that? So again, if you reform the system, if you transform the system in the way that I'm describing, you start to serve people earlier on. They need less intensive care. So when you serve people that need less intensive care, you can serve more people than if they need the higher cost, late stage care. See the transformation starting to play out before your eyes? So earlier on care means we can do it in shorter episodes, treat to target type of models, and integrated care, which is maybe shorter term burst of care for people to help them to get out of this. So this increase in the demand for services is already hitting us nationwide. So I go around the country and do some of this work, and every provider that I talk to seems to say there's more and more people demanding services, and we can't handle that volume. We are full at our capacity. Our caseloads are full. The ratios are out of the roof, and it's very difficult for us to manage in this situation. And we just don't have new resources in order to apply to this and add to it. So that's why we should prepare for healthcare reform, and that's what healthcare reform is doing to us. Not all of it positive, some of it negative because of this increased demand and the frustration that goes along with it. But if you participate in it, then you will see you can start to change the system and make something different. Other reasons why we need to prepare for this healthcare reform is to be ready to work with these expanded Medicaid systems, and maybe even also the accountable care organizations. Now, there are no accountable care organizations yet in the state of Kansas that have been approved by CMS, but there are some in the state of Missouri, and I think we're going to see them in Kansas in the very near future. But primary care medical homes and person-centered medical homes, all of these are foundational in the Affordable Care Act that fit and help us to accomplish the goals of improving care. So that's some of the good things Affordable Care Act brings. That it brings the models and the implementation for us to be able to do something. Also, these medical homes are becoming a primary focus of integrated healthcare. And so in the state of Missouri, for example, I know I'm playing both sides of the river, and that's appropriate in this setting. In the state of Missouri, they have been approved for the Section 2703 of the Affordable Care Act, which is the health home model. So now funding is coming to the state of Missouri to establish and support those health homes. On the state of Kansas, that has not happened yet. And I don't know when that might or if it might, but in a number of states where we're seeing this move already. The state of Ohio, for example, the state of North Carolina, where I'm from, the state of Rhode Island, Arizona, all of those are Section 2703 states that have started moving now on these health homes.
Is Connecticut on that list?
Connecticut is on that list, yes, thanks, good. There's a significant movement also to these one-stop shops. I don't know that I think I said this yesterday, I don't know that I enjoy going to Walmart on a Saturday. When my wife drags me there, it's probably about the worst couple hours, you know, of the whole day. But I still go. And you still go, right? Because we go because it's easy, you know? We can go and get about everything, fill up 2 carts, and you make one stop and you get something done, and then you come back home and then it's over with, as compared to going to 4 or 5 different locations. Our clients, when we interview them, that's what they say. They say that our systems are fragmented. We send them all across town. And you also know this is not a surprise, I'm sure. If you ask your clients the questions, your patients these questions, they will tell you that it is hard to navigate our system. We're silent, we're fragmented, we send people all across town to get things done, and it's very hard for them to figure out how to connect up and do all of this. They almost need a personal navigator and they need a personal chauffeur in order to connect up in the right way to all of that. The opposite of that, though, is a one-stop type of shopping environment. You can go to one location and get a menu of all the different services, sort of the cafeteria model, where that you can get all those kind of things. Well, that's what's becoming prominent in our nation as a way, or the delivery system, and that's where integrated care seems to fit right in perfectly well. So one-stop shopping for healthcare delivery systems is where we're seeing this go. In the state of Missouri, of course, we have Missouri HealthNet. And again, what they're saying right now is Missouri plans to expand its Medicaid system in 2014. And they're projecting they will add 300,000 new Medicaid enrollees next year. So you see this capacity thing, you see this extra demand, you see that these people historically probably had been non-insured. They did not have a payer source, and that may have been a delay in services for them, or it may have meant that they were getting rationed out of care because someone else maybe had a higher need. So if this is true and if this follows along, we're going to see this demand hit. Assuming the same amount of state money is in the system that some of these people are benefiting from right now, if you add Medicaid to this 300,000 and the state money stays the same, essentially another piece of the population that is uninsured can now get into care with some effort as well. So you can see that this kind of demand is even more so becoming popular and something that we're going to have to address, because these individuals will have fewer delays. They'll have fewer barriers to get into care if all that works out. So I just did a little math here. So if 20% of that population, 60,000, have a behavioral health condition, which comes from the national data of 10% have an addiction, 7% have a major mental illness, and 3% have an intellectual and developmental disability. So you get your 20% from there. 60,000 now have a behavioral health condition in this 300,000 population. Who are going to give them the access to care? Who is going to do that? You know, and how do you divide that up? So if all of you were one of those providers, if this was the entire subset of the population in Missouri for for the treatment array, then we would just go around each of you and we'd say, okay, we got to bring up 60,000 people. Which 5,000 do you want? And which 5,000 do you want? And we just go and divide them up. You know, and all of you would be scared of that because you would say, how in the world would I bring up that many people and bring those into services? So there's part of the challenge. So we've got to do more integrated healthcare to serve people earlier on and to diversify this structure of services. So what that means is that people with mild and moderate illnesses, mental health illnesses, may be served in primary healthcare environments, and people with major mental illnesses and major addictions would be served in specialty behavioral health environments. And we start to segregate that population based on the level of care that they need. So a level of care model would say, if you can be treated in 10 sessions or less for your depression, why not do that in primary healthcare with an integrated behavioral health therapist? And if you need major mental health treatment that's long-standing, like for schizophrenia, bipolar illness, major depression, then a specialty behavioral health care service provider with integrated primary health care to address your physical health needs is maybe the best option for you. But right now, we have people from both sides crossing over in the wrong direction. So we have, and I bet well, I've already met some primary care people in this room today. So you have primary care patients that have the major mental illnesses, and you think this is really inappropriate for them to be in my practice. You know, they're too severe. We don't have the skill set. They need a specialty healthcare provider for that. And then we have in the specialty healthcare arrangements, we have people with chronic health conditions and maybe mild to moderate mental health needs, and those can be served in a different location. So you start to see this pattern. When you integrate care, you can move people to the right location to get the right service. That's the theory, and that's how it's implemented when you put it out there. So that just gives you one example. Now, as I said earlier, the Section 2703, part of the Affordable Care Act, is something that the state of Missouri has won. There were 15 states, by the way, that were given that authority by the Center for Medicaid and Medicare Services last year. Of those 15, 8 of those states are moving forward, have the green light, and have money. And Missouri is one of those. The emphasis, again, is to increase the health status of Missourians through better coverage for healthcare services, access to those services, quality of those services, and accountability to taxpayers. Do you see the triple aim embedded in here? See it coming about. Okay, that is what the state of Missouri says they want to do with that. So here's the challenge, a big challenge when we think about integration. A lot of other things we're trying to accomplish here. We really want to reduce the readmissions, and these readmissions again are for really higher levels, higher costs of care. So that's one of the big challenge. And what we know about that is that the failure to adhere to treatment, the failure to follow up the treatment, the failure to engage in treatment, and I probably shouldn't use the word failure because I'm not trying to put blame, but I'm saying when someone doesn't get what they need, they likely are going to get readmitted if they've got a serious illness. That's the bottom line. So what are we doing? So remember when I gave you the example of my accountability as a payer now, that I'm responsible for the people outside of this building that are not in somebody's professional office, that are not getting the care? When I take that and I assume that role and I say I am accountable, that means I've got to have people like Scott. I'm going to say, Scott, I'm going to pay you to go out there and get that person and engage that person. Because if they disengage from us, they might be readmitted to a higher level of care. And who's going to pay for it? In a payer system like mine, I'm paying for it. I'm going to pay for the hospitalization. I'm going to pay for the high-cost care. I'm going to pay for the emergency room care. And I'm doing that right now in the state of North Carolina in my 8 counties. I'm at full risk. That's what managed care does. And that's what has happened in the state of Kansas with your big 3 managed behavioral health organizations. They are at risk for that. They are under the same waiver that I'm under, so I can speak just like the Chief Executive Officer for Optum right now. They're under that full capitation. They've got to provide better care, they've got to reduce the cost, and they've got to improve access in order to do all of that. So by improving access, if I just watch that person walk around out there and didn't do anything, then what, they could end up in some of these higher cost care. So I need Scott to go out there and do it. So Scott, this afternoon, I want you to go out there and take care of those people out there. So Tracy, I got a job for you too. So the next big challenge is that we've got to reduce the future medical costs of this population. Again, integrated care is part of the answer to that. We've got to appreciably impact that cost. Again, we may see a spike. When you first do a conversion like this, you may see a spike because you're opening the access door. I use a lot of North Carolina analogies now, and I'm going to use another one. So when you go from a doggy door to the garage door, and you open that access, then more people will come in the door. And you're going to spend a little bit more money at first. But again, if you kept people out of the service system, then you delay care, and when they do get in, they're going to cost more. So what we want is to get them in faster. So more than half of the inpatient admissions, what we know about this is more than half of the inpatient admissions had minimal to no engagement with behavioral health delivery system in the prior year. Now, as an example about that, using the person out there, and Scott, he's going to be my engagement specialist. So again, if he doesn't engage that person, if he doesn't get them into services, they may become one of these people that will eventually get back into the system, but they're going to get back in through an emergency department. And what are you likely to do when you get into the emergency department? The emergency room specialist may involuntarily commit you, and you're likely to go to an inpatient center. And now we're talking about high cost care again. And also when the court system says you got to stay in a hospital, but the healthcare payers have to pay for it, then you've really lost some of the medical decision making. This is now coercive treatment. And in fact, in North Carolina, they're called respondents, not patients, when they're on involuntary commitment. It's a change of the whole environment when that happens. And your situation may be similar. Informing consumer choice. When you offer this to people, 25% of consumers who are given more information about treatment options actually choose a less intensive option or service when you give them options. I had this happen just recently. I don't know if you know a lot about the mental health services. I bet some of you do. But are y'all familiar with a service called Assertive Community Treatment Team? Okay. And are you familiar with another service called Community Support Team? I think you're probably, we talked about community support teams yesterday, in fact. So that ACT teams are a little higher in level. Community support teams are right below it. So we had a patient recently that I became accountable for. This patient got out of prison, had been in prison for the better part of 15 years. A young man in his mid-30s. So you know he'd spent now a lot of his life in a prison setting. He has a major mental illness called schizophrenia. And he also has a substance use disorder. So 2 chronic health type conditions, both of them on the behavioral health side. And very bad family situation. Things were really not going well for him. So he comes out of prison. And unlike some of your opportunities and advantages for people in prison that I learned about some yesterday, when he came out, he had no Medicaid because you lose Medicaid when you go into the prison system. So, and that was not transferred out when he got out. So he got out uninsured, no health plan, no anything, came back to the community, and it became partly my responsibility. So, so one of our providers assessed him and said he needs ACT team in a big way, and he needs all kinds of other wraparound services. The client said to the provider, I looked at those options, and I really don't want that ACT team, because if I got ACT team, I'm going to have to lose a service called psychosocial rehabilitation. Kind of a supportive service with vocational support training and opportunities, education, and some socialization and normalization to the community. And he really wanted that as his dominant treatment. And the provider said, no. The clinical algorithm and the evidence-based practice says you fit ACT team, and if we don't give you ACT, you may go back to a hospital, you may reoffend, you may go back to prison. Well, there was a lot of consternation about this one, and he had some advocates within the community, some families that had kind of taken him in and all, and they all came over to my door and said, you need to intervene on this because those providers want to do ACT team, and we really believe in him. We want his choice to be honored. We want something less than that. So I'm looking around, I'm looking at my UM department staff. I got 62 UM people, and they're all very talented professionals, and they're all scratching their heads saying, you're not gonna make a change in this, are you? You know, and I'll tell you what I did. This was actually last September. I did say, why don't we try something different and unique? Let's divert from the practice. Let's allow him into CST, that service, which would allow him to get psychosocial rehab at the same time. And let's see how it works and give him a month. A lower level of service at a lower cost, by the way. So I'm paying less money. But the risk I took is that if he went to the hospital, I'm going to be paying more money if he did that. Today, he's employed. He's at the psychosocial rehabilitation program probably right this very minute. He works in the afternoons. And he has got a driver's license. And he has now got an old beat-up car. And he is living independently in an apartment. And he is also on disability. So he's got some disability coming in, but he's working part-time. In other words, he's regained some of these things that he wants. And you know what he said to me when I was asking him questions? He said, all I want is my life back. All I want is my life back. So, but it fits this model. This fella, we met him halfway. We listened to what he wanted, despite my clinical best judgment that he probably needed a higher level of care. And it worked in this case. It probably won't work in every case, but it's just another example of why it's important to listen to people, and maybe why it's important to give them informed choice, because sometimes they can make their own decision. In fact, I said to him, look, if you don't do well with this, then you're going to be hospitalized, and even worse, you might go out of prison. That's not going to be a good outcome here. And I want to lay that out as part of the risk that we're assuming here. Managing behavioral health crises. More than 40% of mental health cases in an emergency department are admitted versus less than 5% of medical cases. Fact. So when our patients go to the emergency department, it usually will result in an admission at least 40% of the time. And once again, we've got to bend the cost curve and get the most appropriate level of care. It's about access again. If we could give people the access that would have gone to the emergency room tomorrow, give them access this afternoon, maybe we can avoid that happening. And then treatment adherence. 17 to 22% of another challenge here, 17 to 22% drop out of psychotherapy prematurely, and they're 3.75 times the risk of psychiatric relapse with medication noncompliance. So that tells us something about engagement. If we don't go and get people, if we don't engage properly, the adherence rate will be high. I'm sorry, the non-adherence rate will be high, and people will relapse or drop out of care. And when they do that, they often land back into higher levels of care. So all of these challenges are out there, and again create the foundation for why integrated care may help to answer all 5 of these.
David, can I ask a funny question without trying to get you all the way across the map?
Yeah.
Because, at least in my head, I sort of grasp this side because I'm on the behavioral health advocacy side. Are these challenges that are here listed for behavioral health providers sort of mirrored in the what, below the neck healthcare providers, that some of that reducing readmission, they're showing up, they're not getting this psychiatric, and that some of the medical providers, their readmits are coming out because there's not treatment of the psychiatric stuff? Or are we looking at dramatically different animals?
I think it's more of the same. And the reason why I would say that is because a lot of reasons why some of these things happen is because people don't get the proper medical care for their physical health conditions simultaneously with their medical health care. And integrated care brings that answer to it. And there's actually, I think there's a little research I've got coming up that'll let you show you that.
BHCommunityDavidSwann, so it's not concurrently being treated.
Exactly.
And so if I'm always sick, I might also deal with depression from being chronically ill.
Yes.
And one's treated, the other one's not, so.
Carla and I were talking about the sweet spot on Monday. The sweet spot of this thing is when you collaborate with both and bring both together. People benefit the most because we really squarely hit it on. Anything off, if we do physical without behavioral or behavioral without physical, we miss the sweet spot. We will hit it off. We may do something advantageous for the person, but it doesn't get right in the core of what we're trying to do.
Whole person approach, which you'll
That's
talk
right.
about later.
The whole person approach, that's it. Great question. And again, this is a dialogue. Other questions that come up about this? Okay, great. So this is team-based care also. And this is why this is a challenge for us. Again, and this is why I love what Mark is doing. They've become a catalyst today. They've pulled together a team of people that even spans states. And state lines don't really matter when we're sitting in this room right now. You have formed yourself as a team. Scott was just talking about every third Thursday, I believe, there's a meeting of a team that is looking at this and trying to figure out how we can improve healthcare and raise the healthcare bar so that more people can benefit from this. So this is really an opportunity to redesign the whole healthcare system. And I'm using the term bidirectional approach, which I've already described. I just didn't use the word or the phrase, but I've already described it. Again, that's when the more appropriate level of care is provided in a primary care environment, or a more appropriate level of care is provided in a specialty behavioral health environment. But you're redirecting how people get into the system and getting them into the part of the system where they can benefit the most. So, and we'll just come back to that one example. A person with mild and moderate depression may very well be able to benefit from an integrated behaviorist in a primary care clinic where there's collaborative care around their physical and behavioral health service needs. But that's not long-term care for their depression. So if they have a major depression, where they've been refractory to previous treatment approaches, they're going to need specialty behavioral health care, but they still need attention to their physical health conditions. And what we know is when people have serious mental illnesses, they're also more than likely not to get physical health care. Now, some of us were together yesterday, and I asked one of the large organizations of the population that they treat, do they ask a question like this? Do you have a primary care doctor? Yes or no? Simple question. And then the second question, have you seen a primary care doctor in the last 12 months? Just two very simple questions. They said 95% in Kansas City of their population do not get either one of those. The answer is no to both of those. So 95% of people with serious and significant illnesses don't get access to primary health care in that one healthcare environment. And their population was 7,500 is what I think I remember them saying. 7,500 Kansas City citizens, that have serious addictions and mental health needs don't get primary health care based on that question from their data set when they admit them. Now, I know you're not satisfied with that. I know that's probably one of the reasons why you're here. I know that's one of the reasons why you think about integrated healthcare. All of those, that's just a clear justification. So these illnesses keep people from engaging in the primary healthcare. And now what do we know is the outcome from that? People have serious consequences and often early on death as a result of the physical health problems that come about because they have a delay or somehow are unable to get access to primary health care and to get the preventative types of services and the intervention services that they need. So this is an opportunity to redesign. It does include health home development, and I know Scott was just saying a while ago, I think your next session is going to be on some of the sustainability of integrated healthcare. I'm going to hit a little bit of that today, and I'm just going to touch it right now by just saying there's payment reform options. Payment reform options come also with the Affordable Care Act, and those look like pay for performance or pay for outcomes. I'll give you one of my true confessions. In my early days, I would have seen a patient as many times as the patient would have let me see them, and I would have billed a payer and have been paid. 30 years ago, that's the way it was. And I would have, and if you'd asked me about my outcome, Dick, I would have said, oh, what's your first name?
Bobby.
Bobby. I've seen Bobby for 3 years in a row every week. Isn't that wonderful? And he's just got to be so good because, he's getting so much good care. Nowadays, what was your name again?
Danielle.
Yeah, Danielle would say, why is he practicing? Is he that bad? He has to see Bobby for 3 years? The exact opposite question is asked now. Paying for performance is nothing different than that. It is a payer saying, we're going to pay for an outcome. We're going to pay for an outcome and not a volume of services. So fee-for-service is going away. And the Affordable Care Act takes away fee-for-service and puts in 8 different models of payment systems that work well with integrated healthcare and health homes that allow you to pay for outcomes. And in my organization, now that you know I'm a payer, I told some of this team yesterday that right now about 15% of my 900 providers in my network are under a pay-for-performance contract. Come July 1 of this year, probably 65% will be under a pay-for-performance contract. Right now, I've got all the crisis services under pay-for-performance. So I went over to Dick and I said, look, you know, I've been buying this facility-based crisis and mobile crisis service from you for a number of years, and I appreciate all of what you've done. It's been really great. You have done a lot of volume. But come July, I'm going to measure you on how you keep people out of the inpatient center. And I'm going to measure your performance on how you keep people out of the emergency department. And I'm going to set a benchmark. And if you stay under that benchmark, I'm going to reward you financially. If you go over that benchmark, then I'm also going to take money away. So, and he's saying, okay, you know, I'll agree to that. But how is he going to do it? He's going to have to open access. He's going to have to engage people in health homes. He's going to have to get people earlier on, and he's going to have to get Scott to go out there and engage somebody on that bridge. Because if that person slips through and gets to the emergency room, he's now financially sharing the risk with me. I've essentially closed that risk for me. I've said, I'm going to give you what we think this is worth plus 10%. I have covered my risk. And he's accepted that and saying, I believe I can do it for what it costs, under 10%, and the margin there is what he's going to take home if he does it. But if it costs 11%, he's going to have to come up with the funding for that.
Based on what you just said, though, would there be some acuity index that, let's say he does go over, but he can show the acuity index of that population? He didn't want to take additional risks because if somebody went out and committed suicide,
exactly,
he might come back and say, look at the acuity, and how they're going to measure acuity.
Yeah.
That might have to be adjusted because of the area that they're serving or population.
That's a great question. How about if I repeat it, because I'm not sure that everybody got that in the question.
I was just going to ask you if you could repeat that.
Okay, no problem at all. I'm going to reframe it, but you, Bobby, tell me if I've got it right. The question was that should we stratify the population on a tiered approach for a episode of care rate, for example. So let's say that the population that Dick is going to serve, there's 4 different levels of those. And we determined that level 1 has an episode of care rate of this, level 2 an episode of care rate of this, and 3 and 4, essentially a differential rate structure for the level of acuity that the patients present. I might bundle that all up in one contract, and he's going to get one big check or one check and 1/12 every month, something like that. But you're exactly right, Bobby. There is some justification. And if we were negotiating, I'm sure he'd be smart enough to come at me and say, you know, if you give me 1,000 of those people and 200 of them have a major mental illness and have a history of being hospitalized 4 times in the last 12 months, then I need a different tiered rate for that 200 than I need for the other 800. That's the stratification process. So you have to know something about the population. And that's what's important about that. So it's shared risk, but it's shared risk in a controlled environment. But I just...
David?
Yes, ma'am?
I would add, you know, one further thing to that toolkit, especially if an organization is considering, you know, risk stratifying their patient population, which is the tools to manage that risk stratification and the tools to share that workflow and that reporting and all of those, the care coordination that has to happen around those patients. So I think as we develop those pathways that we're going to manage our patients across, and this is certainly, you know, Mark, you know, is engaged in providing this to your community. Also, the tools and technology, that infrastructure as well. Mm-hmm. And certainly that's why I'm dialed into the call today.
Right. See, this is very sophisticated healthcare management, I think. whenever that you can do something like that, and I'm going to say it's a stretch for us in behavioral health care. We're just becoming of age to be able to do these kind of things. And sometimes when I'm approaching my providers in my network and I talk like this, you know, their eyes start to kind of jump around and they look a little bit white. And I think, okay, this is something that we all have to get over. And I mostly want to make the point that we're moving in this direction. I think there's some safety for providers that needs to be built in, because we don't want to lose providers in the mix of this, but there's got to be a transition from accepting no risk to accepting risk. And when you do that, what are the services that you need to provide to deliver that risk management? And one of those is integrated healthcare, so that you can open access and you can provide better care earlier on to people. Okay?
And ostensibly, the below the neck folks are struggling with the same piece,
Right.
with stratifying. Okay, I'm now going to get these new covered lives, and X percentage of them have, you know, a very mild episode of depression, and Y actually probably have bipolar, now that I've looked at it a little more carefully, and so I need to stratify my folks. And I suppose theoretically we're going to have a system to send them back and forth when, when primary care gets someone whose bipolar looks a whole lot more serious now that we've had them for a while, or behavioral health gets somebody who looked like, boy, all that was really going on was a little diabetes, but we can't get that under control. I guess part of it's not only the stratification of the population in each, but the ability to move them back and forth as needed.
That's correct. That is correct. And this whole team-based care model is seen and viewed as the optimum approach to managing that kind of population. So if Dick doesn't have all of those options, if he doesn't have that array of services, he's gonna have a difficult time meeting those expectations. And so that's really what's critical about this. There are challenges, and this is part of the answer to that. Again, I've just put in there the creating the extra capacity that's going to be needed to manage a population like that. Not only the expanded population, but once again, those people that are not engaged with care now, or those people that we count on no-showing. You know, another little true confession. I used to enjoy no-shows 30 years ago. You know, I might have 5 patients scheduled in a day for hourly visits, and 2 of them no-showed. I turned out to be doing 3 hours worth of work. I'd have a little chance to call my wife at school. I'd have a chance to check on my son. I might, in those days we didn't have computers, so I couldn't do anything like that. I might even take a little rest in my easy chair, you know, at the office. And I got paid the same thing. You know, those days are gone. Those days are gone, and I was not accountable to those patients. And I wasn't concerned. In fact, I got excited about, in a happy way, when sometimes people would no-show. I'm embarrassed to say that's the way my professional life started. That's the way I was taught, by the way, too, in school. You know, nowadays I'm concerned about a person that no-shows, because Dick and I are saying, hey, wait, we're sharing the risk. If someone doesn't come in, where are they? And what are they doing? And what's going to happen to them? That's the challenge that we've got to get fixed. So this additional capacity is really important. So when you look at just improvement in access, and we've said a lot about this, but let me just expand further again. When you look at parity and national healthcare reform, again, more people, will have an opportunity and have fewer barriers to get into care. When you have specialty behavioral health organizations that now are going to have to expand capacity, how do they do that, and what do they do? And the bottom line is the patient-centered medical homes, or health homes, and I'm really genericizing that today. I'm talking about any kind of integrated care environment. If it's a health home, as you understand it, a patient-centered medical home, or an integrated behavioral health home, any one of those types of models must provide integrated care for persons in order to help to achieve some of these goals and to make this happen. So better care now, so access first now, better care, medical homes and health homes are becoming the primary focus of this integration of care, which is connecting the head back to the body. Another one of those things, probably a lot of us, if you're close to my age and experience, you were taught the head and the body were separate in the 1970s. We somehow put them back together again, you know, throughout the 80s and the 90s. And so we've got, again, these significant movements to these one-stop shops that are seeing here. And again, how to bend the cost curve. Kind of in summary, just how to bend the cost curve. We must all be ready to work with these expanded Medicaid systems and all, and to try to reduce this cost. And I put in here our example. North Carolina, again, is operating under this carve-out Medicaid 1915 DC waiver. And that's what I'm running, again, fully capitated. So once I enter into a contract year with Medicaid, I get no more money and no less money. If the enrollment of Medicaid goes up, I'm at risk. If the severity of the patients that we treat goes up, I'm at risk. My organization is at risk. In other words, I have to manage within that. This is a way that states and federal government are controlling Medicaid costs. So the federal government to North Carolina says, this is a wonderful day on July the 1st. We sign an agreement and the federal government knows exactly how much Medicaid match it's going to provide for the next 12 months. And then North Carolina signs a contract with us. And North Carolina says on July 1, we now know exactly how much Medicaid money we're going to be sending out there to Partners Behavioral Health Management for the next 12 months. No more and no less, and the budget is fixed so we don't have to go back and redo that with the General Assembly. It's really a great day in the state of North Carolina. And then on July the 5th, 10 more people go into a hospital than the day before. And by the way, every single day I'm tracking hospital admissions in my 8 counties. Since we've been here this morning, somebody has sent me an email from North Carolina and it's got my emergency room stats and my inpatient stats. And I know the names, I know the particular cases, and I know how long they've been waiting in an emergency room. And whenever they wait more than 24 hours, it's color-coded red for me to pay attention. And it means call the hospital CEO before they call you. And so you beat them to the punch and you say, I know someone's been in your hospital for longer than 24 hours in the ED, and we're trying our best to get them out to the right placement. But those types of things, and now we're financially accountable for that. So just as an example, again, trying to bend that cost curve, you integrate the healthcare though, and you collaborate and you find that sweet spot, and again, it costs less to provide that care. So the big three again, access, outcomes, and cost. Below each of these are some of the items or some of the ways that you can do this. This is a little bit operational, so if you're looking at what you can do, if you're a primary care specialist or if you are a specialty behavioral health care operator, just think about how you could do something different. Can you provide services earlier on in the course of an illness? Remember those commercials from a long time ago, early treatment means an early cure? Those types of things are kind of the motto here. How do we get people early on care, and can we do it earlier on in the course of an illness? I think we'd all agree that in any illness that we know of today, if we could intervene early on, then quite possibly we could mitigate maybe the lifelong impact of that. We could mitigate the physical impact of that illness on that particular patient. No-show management. This is a cost to each of you. So now it's a cost. It's not only a cost though. A greater problem that I see is that you lose capacity. So go back to the extra capacity needs that I was speaking about earlier. We need more slots, if you will. We need more appointments. We need more schedules. We need more people serving more clients. And if you lose 20 to 30% in no-shows, you've lost 20 to 30% of your capacity. And when I go around the country and work with mental health programs, the average no-show rate in some of these places is 30%. Now, there are techniques and strategies to reduce that. Those that do so can bring it down to single digits. I've not found anybody that can do a zero out yet, but I know a lot of places that are running 8, 9%. And that is huge if you started off at 30. You see the extra income you just brought in, but again, more importantly, I mean, the business office is happy. But more importantly, let's think about the capacity that we just did. If you have 10 therapists, each that are all working in a full-time capacity, and you set 65% as their direct service time expectation, which is a national benchmark, by the way, that's 5 billable hours in a day. So that's 25 billable hours in a week. If you have 10 therapists who only do 3, like I did 30 years ago, you have just lost 20 billable hours of care. And that's 20 people or 20 services that maybe in the community needed to be provided, but you kept people out because you were losing that type of capacity. So the business office gets happy when you bring those in, but I think the clinical side of your business gets real happy too. Same-day access. Now, some places around Kansas City, and both Missouri and Kansas, are all working on that right now. I have been helping a number of these centers and sites to operate same-day access. Very simply put, it runs like my primary care doctor's office did. If I got sick last night and I'm back home in North Carolina and I needed to go to my primary care doctor, when will the phone ring at the primary care doctor's office? Between 8 and about 9 o'clock. And it's going to be me on the other end. I say, hey, it's David. I got sick last night. And they're going to say, we'll work you in. That's how primary care works. Behavioral health care has to adopt the same kinds of things. Same-day access. And this hadn't happened right around this percentage, but we're getting really close because this is a bold statement. But in another place that we've worked at recently, we had the mental health provider send a letter to every primary care doctor in the community, and the letter went like this. Dear primary care doctor, we're excited to inform you that beginning next Monday, we will institute our same-day access protocol for any of your patients that you want to refer. If you call or contact us by 3 p.m. on any business day, we will see that patient on the same day. If you call us after 3, we will see them on the next business day. Thank you for your attention. The primary care doctors absolutely doubled over, beat up the roadway to get to those mental health providers thanking them. Because what's the biggest complaint from the primary care practice world? Can't get anybody in, right? Can't get anybody in. It's a black hole. If you do get someone in, you never hear back from them. So this large mental health program was able to say that to their primary care practice in the community, offering same-day access. So same-day access and integrated health care go together because you want to be able to do those in a combination. And again, it's a primary care practice model for that. Reducing the time from the first call to
I don't want to be stupid. I've got a husband who's a therapist in a community mental health center. He actually doesn't have a no-show rate, miraculously.
Yeah.
There are not very many male therapists, and so people realize they need to get there. But what the rub that I start to see is if my therapist is scheduled a patient on the hour, every hour, and we have no no-shows, which is great because, I mean, I get that. I'm like, I'm sorry, you're working like heck, but you know what? That's no money, no mission. I get that, but then where do you put the new people in who are coming in? Because he has no no-shows. There are no slots in his schedule.
Right.
Where do you get the paperwork done? And where do you get him to call back to the primary care physician to say, I did see that guy?
Right.
Because when you have that, I don't want anybody to be having a 30% no-show rate. But when you're pushing down to 0 or nothing,
not much time.
Well, and what I'm seeing and hearing is that you've got some pretty exhausted therapists out there who are going from one thing to the next, to the next, to the next, and they are not getting enough breathing space to do the best therapy or the best connectivity. And some of what I've heard in the larger groups, not just in my personal life, is how do we build for the consult to call back? How does that piece work? How do we build that in with these other pieces?
You asked a lot of questions in that one big sentence.
Sorry.
But no, don't be sorry. No, it's just I'm going to try to remember it all, and I'm going to get to some of the payment stuff in a little bit. But you have, I think your question is best stated. How do you operationalize something like this? And let's just say that this table, which would include me, 4 of us, are with one of these broader organizations. So one of the ways you operationalize this is each of us on any given day. Well, I need to make it work. So let's just say it's Wednesday. So each of us is going to take a 2-hour block of time, and we're going to be running the same-day access. So I'm not going to have scheduled patients between 8 and 10. You won't have them between 10 and 12. You won't have them between 1 and 3, and you won't have them between 3 and 5. We are available in the office, ready to see the person coming in on the same day. Then, your next question is, what happens for the second visit after that? We are, again, building capacity. If you have zero capacity to pick up, everybody in the center is flat out, full-blown, just like your husband, so there is no vacant time. You have to add staff in order to add to the capacity. But you're not adding it without additional revenue because you're going to be bringing in additional services when you do that. So there's two low-hanging fruit. One is that if you can pick up no-shows and capacity that's currently vacant, and most places can if they're a big operation, and I say big, relatively big. Solo practitioners may not have that option, but practices with 2, 3, 4, 5, 6, 7, or 150, they'll have magnitudes of different kind of no-show capacity they can pick up. So if you go from 30% to 15%, you cut it in half, then you don't have to add new staff in order to bring in the people up to a certain point. Then once you hit your maximum capacity again, you have to start adding people. But as one of the centers recently that we worked with just brought in another $300,000 to the bottom line because of no-show management. And so there was quite a good opportunity to now start hiring additional staff to bring in additional work. So think of it as a domino effect. There's no one thing that you have to do. It's a multitude of things you have to do in layers that starts to expand your capacity and care. You manage your no-shows better, you reduce the no-shows, you bring in more money, you hire more staff as you need it, and you expand your capacity, you serve more people, and you manage your no-shows again, and then you hire more people and you keep expanding. It is a domino effect. You're peeling the onion as fast as you can. It's the only way to build these capacities to where that we need it. And I think if you've seen that, or if you've done something like that before, you probably have felt it happening. And if you could just keep that trend going, and you sort of do that. Now, I'm going to say too, just while I got it on my mind, some places will not be able to do that. And some places will have to join up with other providers in order to make that happen. So there's another potential outcome here is that smaller providers become larger providers, not because of their growth, but because of joining up with others, again, to form larger systems to where that people can get in and have one-stop shopping opportunities.
And I'm assuming some of that may happen in some of the farther out-state places. There are community mental health centers in Kansas where you not only don't have very many therapists to move around there, you don't have a pool to draw from to hire more.
Yeah, one of the other questions you asked too is about the kind of case management work that kind of goes on in between that fills in the cracks. And in order to afford that, you have to have a large enough capacity of clinical care to do it. So you're cost shifting from some of your daily regular care to do something like that. And when I start to talk about the payment reform systems, I'll tell you how you can afford some of those too. And some of that is already happening in many of the states right now. By the way, also know that in Kansas, in your state, that the 3 MCOs are getting ready to talk with the providers about this kind of performance-based contracting effective July 1 of 2013. So they are moving along in exactly the same way that we are. So then if you want to look at, I stopped with the reduced time from first call to treatment. What do we know about that? And if a person comes in or if a person makes their initial contact and then the treatment intervention takes a long time, I'm going to ask the question because I want some participation. If you increase the time between that first call to the first treatment, what's likely to happen? A crisis? Or what about the person just not even showing up? Or they're just going to drop out?
Right.
And would you all agree that the longer that you go, the less likely that they'll probably be engaged? So what do we know about that then? The science is you bring it as close as possible. So when I talk about same-day access, that's another one of those gifts that really helps us to engage people. Yesterday I told the team that my mom taught me this when I was a young child, to strike while the iron's hot. And and so maybe it's a North Carolina term, but I try to think that applies to our work as well. When someone says, I need help, then give them that and they're likely to get engaged. If you delay it, then they'll say, well, blah, 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 it might not be that way. I think I told some people at the Reach Board meeting on Monday another kind of really disheartening story at my center several years ago where I was at one of the clinics and I was leaving the door and there was a lady going out at the same time and she was obviously been into some care. I didn't know anything about her, didn't know first session, 100 session. But I just happened to say, hi, my name's David Swann, I'm the CEO here, and I just wondered how your experience was today. You know, the general walkabout and, you know, executive level stuff, you know. She said, oh, it was lousy. You know, gets my attention. Tell me more about that. Well, I've spent 2.5 hours here, and all I did was answer questions for your staff. They filled out a bunch of documents, and I waited for a long time, and then I filled out...
www.webex.com.
I wonder if that's the lady that's dissatisfied. So I think our caller probably get disconnected somewhere. That's a Sprint thing. So you know, I said, well, tell me a little bit more about what's going on. And she said, well, I just you know, I know better now after 2.5 hours. And I said, well, how did you get here? And she said, well, somebody drove me. And I said, what will you tell this person you're going to get in the car with? She said, I'm going to tell this person I get in the car with that this is no place, you know, to be. I mean, they didn't help me out at all. They just helped themselves by letting me answer their questions. And I said, how likely are you to come back? Now, and I bet you know the answer to this one.
Yeah.
She was very honest. You know, the likelihood was not good for her to come back. And I was realizing that I was losing the engagement of someone that really needed to be in our services. And said to myself, since something's got to change, we did not do a good job there. We've got to do a better job at reducing the time from the first call to treatment, and also reducing the barriers to someone feeling like that they've got something positive from our center. Yes, sir.
It seems to me that one of the areas of improvement is that first response, of rather than having a receptionist that just passes calls, to having somebody that really listens to what's needed. And then secondly, having case management that is wise enough to be able to take the risk level and set it up with the appropriate service intensity, that coordination. Two things in the current system which you can't bill for.
Yeah.
And I mean, I run into this all the time where some of the happiest customers are those that don't even get in, but are, I had one guy call back and said, thank you for hiring somebody that stayed on the phone and called me back 15 minutes after they got the information I wanted and said, here's what we can do for you tomorrow. Even though I didn't get in, it was so good to have a real person answering my personal question.
And you're talking about an outcome. And you're talking about an outcome in the fee-for-service environment. And that's why I say fee-for-service has to go away. It cannot sustain what you just described that you need to do. I need you to do what you just described. I need you to engage that person. I need you to get them into treatment. I need them to get better. And if we don't do that, if I only pay you for the head of the bed, or if I only pay you for the hours worth of service, we are not going to get that done. That's why this pay for performance has to include something about case management, and that's where we pay for it at. It could look like an episode of care rate with an outcome. It could look like a per member per month rate, where that you accept a shared risk for 1,000 clients and, you know, stratified like Bobby and I were talking about a while ago. There's all kinds of ways to do it. But you just hit the bullseye right there. That has to happen. You can't do this without payment reform. You've got to have integrated care. You've got to have payment reform. Integrated care is not going to work very well either with just fee-for-service. It's not sufficient in and of itself that we just pay for an amount of time that someone's going to be served and cared for. We've got to produce the outcome, pay for the outcome that you deliver. So nicely said. Would you want to take this and finish? Or
Very interesting point, and you rightly described the problem. And what I am seeing is that from a process level, system level, we are all on board on the integration of primary care and behavioral health. There is no question asked. I am told that Missouri Medical Home, which tried their best to integrate mental health with primary care funded by Medicaid, that's only 20,000 patients, and that's less than 5% of the total patients. What is happening to 95% of the other Medicaid patients, and what is happening to the general population? That's where the challenges are. And how do we address those challenges? And in addition to that, I have worked with many physicians who says, oh, this is the same capitated model which we saw in 80s that failed. What things are we different this time to make it a success?
And see, I would say to answer the second question, it did not include patient-centered medical homes in the 80s. That's one key thing that actually is different. And I think with regard to the smaller number of the population, it's back to a stratification, which we talked about earlier. I think in Missouri, I think the amount of chronic health conditions that get you into a health home had to be pretty high, and so it excluded a lot of the general Medicaid patients, and only those in the real top tier were doing it. It was a way to get started, and I understand that. It's not the way to end. We need to move that bar down, of course, and get more Medicaid people into that system. Again, because we got to get above the falls. I mean, all of us, if we had a choice, we would march up above, right? And we wouldn't be down at the bottom. I mean, we would invest 98% of the resources up above the falls if we could. But we know that there's people that are going to slip through. We're going to have some kind of services down at the bottom as well.
In the 80s and 90s also, we don't have, it's easier to have data and sharing of information.
Definitely. Yeah. All of the data management is huge these days, and some of the providers around this area too are now experimenting and getting very involved with a new technology that is an analytical software type application called CMT technologies, and those analytics are using benchmarks, national benchmarks of clinical efficacy to measure their performance and how that they're doing. And I'm just thinking about Dennis's question a while ago too. Is there anybody here from Johnson County Mental Health? Anybody here? I didn't know I recognized anybody, but well, I've actually been working with Johnson County Mental Health for a while, and I wanted to go back to one thing Dennis said. They have hired someone called an engagement specialist, and what you were describing when a person comes in, that's what that person does. It is the welcome mat, the engagement, the Chamber of Commerce model to get people in to that door and to get them engaged in the system. It is hugely successful, and they don't just do it face-to-face, they do it on the telephone too. So their model is that they're starting to call people 48 hours in advance of their session time. So it goes something like this. They're trained in motivational interviewing. So they call up and they say, Jim, it's here it is. It's in the morning on Wednesday. You have an appointment at about 11 o'clock on Friday morning over here at Johnson County Mental Health. This is David Swann. I just want to chat with you just a minute. We have set aside this time for you, and we're looking forward to seeing you. You've got one of the best therapists. I mean, this Danielle is so good. You're going to be so pleased with that. I just want to know if there's any reason why that you could not make that appointment, because we've held that out for you now. And you can see where I'm going with this. I'm going to be engaging Jim, and before I finish that conversation, he is going to get on or off the fence. We're going to get him on one side or the other. If he gives me some lack of confidence or some inability to make a commitment to come, I'm going to say, Jim, maybe it might be better if you attend one of these groups, because Danielle is really so good, and we need to have her for the people that really want to make a difference. But you're important to us. I'd like to offer you a daily group. Every day at 2 o'clock, we have this group from 2 to 3. I want you to come in today at 2 o'clock and do that. I'm going to try to engage him in something else if I can't get him to engage with Danielle on Friday. But before we discontinue the phone, the engagement specialist is going to know whether he's going to do it or not. Then you've got another process that they're going to do. Let's say that Jim is not going to come, and we decide that, but he's going to. So I'm going to offer him all these groups, and I'm going to put him on the list of need to engage, because we might even send somebody out to his house to find him, because we're also very concerned about him. So, I've also got another list of people, and it's the backfill list. And the engagement specialist goes back to the backfill list and says, your first name? Eric. Eric's been waiting for a week to get in. Have I got a deal for you? Danielle is available at 11 o'clock on Friday. And you see my no-show management starting to happen right now? You see how I'm going to get people in quicker? I will fill up. I'm going to make the business office really happy, because we're going to bring in the revenue, because we're not going to let Danielle's hour go unserved. In fact, my performance expectation, and we call them at Johnson County Mental Health key performance indicators, my performance expectation is I will fill 95% of everybody's vacancies, that is my job. And if I can't do that, then my supervisor, Eric, comes after me and says, golly, David, you know, Danielle's sitting there on Friday morning with nobody in her office, and this is, and you're accountable for this. You see how the whole accountability starts to change when you do this? So these are operational examples, back to Sue's question, operational examples of how you do integrated healthcare and how you make that work. So let's just move on and look at outcomes just for a minute. Outcomes, again, like same-day access and engagement strategies, I just talked about them. These new models of care, again, they're coordinated, they're integrated, and they're assertive engagement focus. You outreach, then you do that. And then, of course, you get the costs that are going to go in your favor. It's going to be value-based purchasing because we can't do, as my example with Dennis, we can't do fee for service and get the kind of things I'm describing. We have to pay differently. I have to say, Dennis, I'm going to pay you to engage people and to be responsible and accountable. I'm not going to pay you for just serving somebody on the hour. It has to be something different than that. Another operational tool is collaborative documentation. That's another thing, by the way, Johnson County and Wyandotte County, by the way, have done on the Kansas side. And what we've seen here is that you can reduce your cost of doing the documentation. So collaborative documentation is nothing more than what probably you've seen your primary care doctor do with you as well. You do it with the patient during billable time. You do it, you interact with the patient. And you know what we see is that the outcomes of this are better care for people. It engages the client better because they're participatory in their own treatment plans and in their own clinical notes and documentation. So it's not secretive, it's participatory. And I could go through a lot of examples and show you and do some demonstrations, but we probably don't have time this morning. But just want you to know that if you're intrigued by that, Google it or look it up. And if you ever want anything like that, I can actually provide to you some people who can actually help you pull that off. But you can save money and time by doing collaborative documentation. Did you have a question?
I was just going to add to your last comment about the engagement specialist. One of the biggest benefits, I think, of doing that is that you actually have clients or patients preparing for a session.
Yes.
Rather than just showing up and letting the provider carry all the weight.
That's right.
And I think our outcomes change dramatically when people actually think about what my responsibility is when I take an hour of this therapist's time.
Yeah, it actually creates a balance between the professional and the client responsibility and accountability, rather than being one-sided. I know exactly what you're talking about. I used to supervise family therapists, and one of my comments sometimes used to be that it looks like that you might be doing more work than the family. And it was always that was an intervention question for me, and I was trying to draw attention to how much effort and work that the professionals seem to be putting in, and how that they might not be feeling that successful about how much work that the family is actually putting in, and they haven't been able to figure out how to help them to do it. Nice examples. So, again, maximizing capacity, which I think we've already reviewed in there. So let's move to a little bit of the payment reform. Scott, did I see your hand go up a while ago?
Yeah, I was going to suggest we take about a 5-minute break.
I wondered if you were thinking about that. So maybe this is a good time to do that. So thanks for letting me catch your eye. So Scott says we can take a 5-minute break. I think you had another message for everybody too. There's a pink evaluation tool, and that if they needed any help in filling this out, that I would be happy to do that. Thanks. All right, 5-minute break, and we'll come back. Thanks. Hey. Good. Well, thank you for doing that. I wish I had a better, profile for you. What was it called again?
My future problem is interesting. Problem is depression in my mind.
Okay, great. What if I got it? I've actually met with the Healthcare Foundation people last week. Yes. Right. Yes.
But I'm supposed to.
Why we did it? Well, and what I heard is when we started them 10 years ago as an advocacy organization. But not the best, but folks
Is a big organization, they have integrated all these not
Somebody did ask a question about it. Yeah.
You never walked out without having without having an exit and that last person. That chart with every freaking Step out here for a minute.
Well, I know.
That I'll ask you, and then just tell me come.
Well, now I
I appreciate the start.
Well, I'm glad it's working out. I mean, obviously, we were, as providers, very afraid, very much about prioritizing everything.
And I like reading that stuff.
Closing, basically closing down the health center.
Yeah, that's, we're saving up for and I divested $3. So 65. Everybody. Then I still I want to sleep this night. I'm surprised that's true. I just talk it up to being a dad. I was able to control it.
On the Missouri side right now, I was basically
My son just
Hey, so Bobby, are you a Kansas side or a Missouri side?
I'm Kansas side.
All right, really. I have a private fitness practice. Method I have is free. You know, it's flight or free, or I guess every now and then free too. But I have a manner of dealing with whereby instead of turning this energy on self-destructive, I use self-punishment. It's something that needs to be addressed. It's a need that needs to be addressed and filled. I don't have the answer. I work for myself and maybe other people. What do you do inside? Can you counsel?
No, I'm an administrator for children's psychiatry.
I got an idea here, a program that I call it Path. It's basically called now, it takes care of more than just the person that's a trauma, but it incorporates the kids with the parents, whereby the kids, they're in no age how they play, the parents exercise, and the more you exercise the kid, the more exercise the parent, or vice versa. Besides that, when they get done, if the kid gets installed with fitness, it's going to carry them a long way.
Well, I think it's important you got physical, and I like how you just mental, physical, spiritual.
3 pillars of life, and when all 3 of them are fired on full cylinders, it's incredible.
Well, and it sounds easy, but it's not.
No.
How long?
And that's where my experience, that's my training, that's my because after you have already incorporated, I'm saying if you incorporate the physical fitness after you it's great. The other thing, they don't get caught up in it. Their parents take them, they crash. Parents like that. But I'll continue some information about it. It's just they just know that because I need to get tired from you, man. It's really recognized.
physical health is prevention, heart and wellness.
Right, that is
That comes later, I'm sure.
well, I was thinking, it's just a matter of
What is your office like?
Well, I do individually, I do it out of my house. It's personal training, but I go for the second evening part. In fact, I love one thing. I take people to the zoo that day. And if they have going to the zoo, but when they find out the interaction was very minimal, they really because you got the duck walk, pig walk, you got the bear walk. People have a whole different appreciation for animals.
Are you an adventure trainer also? An adventure trainer? I saw your picture. Just curious.
Right, well, that's one of the acts.
I'm always close, so I'm not able to. We'll see how it goes.
Haven't been a trauma survivor 4 years ago.
I'm good. I'm so happy.
I dealt with it. Yeah, I've gone through very much despair and self-destruction. I found a way. So, I just went to the adolescent conference.
I wasn't planning on somebody trying to relationship.
Well, because that's been my passion, because I've been there.
You mean the trauma?
Are we ready to start?
Yes. We'll have walks with next session. These usually in forums.
Yeah, good luck.
It was me with Chris and it's been with us last
Susan is encouraging me to get started real fast, so
great talking about
I had better do it. You know, those co-chairs in Kansas are tough.
You better watch out for Kansas.
That's right. They can be tough. They can be tough. So. I hope you enjoyed the break and found a little food and beverage and all of that. I can also tell that a lot of you haven't seen each other in a long time because you need to catch up. And I'm glad that that's working for you. So, of course, one of my thrills and pleasures is to meet new people all around the country, and so I really enjoy doing that, and also being a part of your learning and a part of your work. So. We were transitioning into payment reform a little bit to just show you how it was. And I was actually talking with this nice gentleman over here at the break about how certain new services that fit well within integrated health homes are paid in a different way. And one of the examples we talked about was the service called SBIRT, which you may know about, the screening, brief intervention, referral to treatment. It's one of those early intervention treatments that you start again above the falls. You detect an at-risk substance user before they become addicted, and when you detect that, then if you do a brief intervention, you might find that you can turn this around. So I always advocate for the substance abuse professionals in the market, in the area, to use that when they're considering integrating their services into primary health care or vice versa. But let primary health care know your expertise in SBIRT. And it's very simple to do. It takes 3 to 4 minutes. And it does carry a code in the Medicare system. It has 2 codes, actually. And in most Medicaid systems, I'm seeing those codes play out as well. And in fact, in mine, I have added those 2 codes to my Medicaid managed care system. And so our providers can actually bill that. We were talking about a per member per month. So that in the state of Missouri, that's how it's being done in order to try to get some uptake on it. But it's also slow to be uptake, as we were talking about. So but that's just another one of those services of how you might do something like that. SBIRT, and it stands for Screening, Brief Intervention, Referral to Treatment. And I'll just, since you asked the question, I'll just kind of take it into a couple of steps. So what you would do in a primary care or integrated care environment is you would I might say, if I were consulting with your primary care firm, I would say, SBIRT every patient on a stratified layer. So if you have, you're going to have a brand new patient doing an annual physical, do an SBIRT. Depending on the results of that, you might not ever do it again, or you might do it again in 2 years, 1 year, 3 years, 4 years, whatever the term may be, depending on what you might find. And what you would do, go ahead.
What was the last part? Screening, briefing, intervention, referral?
Referral to treatment.
Okay.
Thank you for asking that. Yeah. So what we do is that when you come into the office and you get the clipboard, you know, the clipboard with all the documents on it with the pencil, one of those might be an instrument called an audit, A-U-D-I-T. An audit is a substance use screening tool. It has, I believe, 9 questions, I think. It's 9 to 10, I think. Very simple, paper, pencil. It takes a patient, you know, a minute to a minute and a half to complete in the waiting room. And it asks you questions. And based on those questions, then somebody scores that, usually the nurse or usually the office manager. And then when it gets to the healthcare professional, the nurse practitioner, PA, or the medical doctor, those professionals then look at that score and say, you know, either whether they need to do a brief intervention or not. And I'll just give you an example of something that happened recently that I was working with a large group of primary care doctors. So I just gave them this example. I said, it's Monday morning, it's 8:30. A patient that is known to you comes in. This patient now has hypertension. They haven't had hypertension in the past. What do you do and what do you think? And immediately a bunch of primary care doctors think, you got to think about anti-hypertensive medication. You know, we want to help manage the risk of hypertension for this patient. Sounds really medically logical, right? And then I introduce expert to them. And I say, what if you had done an expert on this person in the way I just described it? And what you found out, because one of the questions on the audit is, in the past 12 months, have you consumed more than 5 alcohol-containing drinks in one 24-hour period? That is the definition of binge drinking. We don't use that word in the audit, but we use the question. So, have you consumed 5 or more alcohol-containing drinks for a male in the last 12 months in one 24-hour period of time? If that person said yes to that, then, and I was the practitioner, I get in the room with the patient, I say, I see you answered yes to this question. Tell me about that. And Eric says, I'll just play for you because now that you're close to me. He says, well, you know, yesterday was that big NASCAR race, you know, in Kansas City. You know, it was Sunday. And me and my buddies, I think I might have drank 18 beers. Now, if you're a healthcare professional, can you imagine that what 18 beers may do to your hypertension within 24 hours? It may elevate your BP in a way that would show you as positive. And when I say that, the medical professionals in the room get scared to death because they just came face to face with medical malpractice. When they say, you mean if we didn't ask that and we started treating hypertension and gave somebody a medication that gave somebody a side effect, that you know, all because, and if we could have only had said to Eric, look, in the next 30 days, do you think you can not do that? And he says, oh yeah, no problem. There's no more races till next year. You know? So, this is what I flew into on Sunday coming in the Kansas City airport is, you know, the NASCAR race. So Eric said, so I said, okay, Eric, look, here's what I want you to do. For the next 30 days, don't use any alcohol. And of course, I'm going to MI him. I'm going to motivational interview him. I'm going to say how likely you'd be able to do that. And, you know, have you ever tried that before? And how successful you think you might be. Let's say he's successful. I have him come back and we do another BP check. What are we likely to find? Maybe his blood pressure has dropped. But if I did not do that expert, thanks for reminding me about this, if I didn't do that expert intervention, we would have never known what potentially the cause was in an integrated health setting for hypertension. And it was substance abuse all along. But if nobody asked that, I would have given him a medication to bring his hypertension down rather than helping him to change his behavior. But even worse, if we didn't catch that early on, above the falls, what could happen later on? Let's say that in my interview with him, he says, you know, my dad was an alcoholic. My dad died 3 years ago from alcoholism. You know, I had an uncle, my dad's brother. He was also an alcoholic. What do we learn? Familial history. What do we know about addiction? It's there. Now I'm going to say something else to Eric. I'm going to say, you know, brother, you're high risk. You're very high risk. It's not just the way you use. Now it's your family history. So I could help him to turn around and get out of that river before he gets over and ends up like somebody else will be behind. So there's an integrated care example of a tool that you can use and something that you can put into that. You see how mental health, substance use, and primary health care work together. And you see the sweet spot coming about when you do that. So, well, let's just move to payment reforms and look at this. So, again, and I've talked about them as risk-sharing models, and that's essentially what they are. They're risk-sharing models where that we offer incentive payments to providers for meeting quality outcome indicators. This nice lady over here was asking me something at the break about quality care and about making sure that we don't forget that. You know, how do we do it? What is the ultimate goal? Quality is quality is quality, and you may have a different definition of that than somebody else, but the payers are going to start telling you what quality is. And it's going to look like reductions in readmissions. It's going to look like stabilization within the community. All of this, and you can just go on and on and on, it's going to look like early intervention. It's going to look like anything that improves the outcomes or that makes life better for the recipients of the care are all about what these kind of payment reforms are going to be driving. Think of it as lean thinking, the modernization of healthcare through information technology and the data sharing. I think we talked about that this morning. And other technologies such as telemonitoring and seamless care delivery. That all sounds better, and I think the research you would find shows that it's better when this is seamless and when there's telemonitoring. Imagine another quality indicator, that if you could, you probably already know that there's about 9 different now technology applications that you can put on a smartphone that are health monitoring technologies. Everything from blood pressure, blood glucose, A1C, whether I took the pills out of the bottle or not, all of those things can be telemonitored now and can go electronically through a cell phone signal up to an electronic health record. And so Scott, my case manager, can look at my record every day and tell how I'm doing on 8 or 9 different things that he might be interested in me. And anything that's abnormal, he can come find me. That's quality care. That's early intervention. That's all of this integration and what's happening with some of this. So when you look at what's going on, if you're a provider of mental health services here today, how many of you are still operating with the same rates today that you had 10 years ago? Okay, there's one. For the rest of you, are the rates lower? In my state, I get an echo up there. I'm going to get back out here. In my state, my 900 providers, I've given them 3 Medicaid rate reductions since July 1 of 2013. 3, you heard me right, 3 rate reductions. They are screaming. This is why that I moved into performance-based contracting. So, and of course it was out of my control, but I mean, they blame me, but I'm having to do it. This is the state Medicaid agency saying, David, you run into a capitated thing, but we're going to tell you that your rate can't be above this. You can make it lower if you want to, but we're going to take it down 4%. October 1, another 3%. January 1, co-occurring with the new CPT codes, they took it down to the 2%. My providers are struggling. And whenever I talk to them, I usually start off by saying, how many of you can take another rate reduction? Raise your hand. And they all, I have to get bodyguards. And so the point is that when you look at this green part here, there's shrinking revenue. You can't do it on the rates that we've got. You can't continue to sustain these kind of programs. So embedded within healthcare reform is more the payment methodologies that seem to help. There's unsustainable costs. There's pressure from stakeholders, which is all the providers, and also you've already heard my message. You got to do more with less. You got to provide more. You got to build your capacity. You've got to do the domino effect. You've got to do more things. And I'm calling for you to be accountable right with me. You've got to be accountable right with me. But I'm paying you about 8% less than I did last July. Doesn't feel good, does it? That's because we've got to change this up. Healthcare reform offers us this opportunity to build from these local strengths and to use these payment tools to better manage. So we're talking about the value of behavioral health services. And there's a number of key factors, and we've talked about most all of them, that will make your value better. I want you to be ready for people like me. I want you to be able to stand tall and strong when the managed care organization says, what value do you bring anyway? If you can get people in and be accessible, and we've talked about that, then you're halfway home right there, because that's essentially what the payers need. You've got to be efficient. Excess no-shows cost you money, and it raises your cost. And I would suggest to you, you have to know what your costs are precisely. Otherwise, how could you negotiate with me on an episode of care rate? Another project I did recently was a very large primary care clinic. They were bringing on behavioral health internally. They were going to serve about 1,000 clients annually with mild to moderate behavioral health. And they quickly realized they could not do it on fee-for-service. So what I helped them do is to negotiate their episode of care rate with a managed care organization. But internally first, we had to figure out what their cost was. So we had to factor in their no-show rate, factor in their salaries, compensation, electricity, all the supports, all those kind of things, and come up with what does it cost them to do an hour's worth of service or a 30-minute piece of service, and then what does it cost them for an episode of care? So if they treat a depression, a mild to moderate depression, can they do it within 12 sessions, 8 sessions, 15 sessions? What is it? They have to know that. And then they have to know what their outcomes are before they can come to the table and say, I'll do it for $500. Because if they go and they offer that up and it really costs them $700, they're in trouble. Right? So you've got to know how efficient you are. So all providers have to work on this. We've got to do this at the lowest possible cost. Make sense? Utilizing electronic health records with the capacity to connect with all other providers. So you've got to build your electronic systems that can talk to one another and that can share information. The patient-centered medical home standards published by the National Council for Quality Assurance tell you what you have to do on the electronic transfer of clinical information. And it tells you how easily that you have to do that. The one I've shared this week is the 1 or 2 click clinical summary. That's in the standards that the patient-centered medical home standards have to comply with, and you have to be able to do it with 1 or 2 clicks so I can get the clinical summary out to another provider when I'm trying to connect up somebody else. What's the biggest complaint between primary care and specialist and behavioral health care? Is that it's either hard to get them in, or then when you do get them in, you don't hear anything about it afterwards, and there's a lack of communication. In other words, I need to know if I'm the practitioner on the behavioral health side, and if this gentleman is the practitioner on the primary health care side, it would be better if I could know what he's doing and he knows what I'm doing without us even talking, because we're busy professions. It'll make it easier if I can look at that and he can look at what I'm doing, and we might not even have to have a conversation. We still may, but it's not necessary. But years ago, we based a lot of this on our need to talk. And that slowed things down, because for me to call him and for us to actually connect, we're going to have to do that 5 to 6 times. It'll take us 3 days. And by that time, it's a little too late for this patient that's in my office right now, and I need something that he has. The focus on episodic care needs and bundled payments. There's your bundled payments. But episodic care needs are another fundamental change in mental health that fits with integrated health care. I'll do my true confession again. So 30 years ago, I wanted to know, what's your first name again?
Michelle.
Michelle, I wanted to know about, Michelle, her mother spanked her when she was 5. And I really want to know about that, because I'm sure there's something that we're going to have to deal with. And so, because I'm planning on seeing you for 5 years on a weekly basis. So I got to know things like that. And now, that first boyfriend, now, when you broke up, was it like the night before the prom, and then, you didn't have the prom date, and I know that was bad for you too, and I'm sure that's affecting you today. I want to know all of that stuff, and I'm exaggerating the defect and making light of something that's maybe not that light. But what my point is that we did that, and I did that in order to get a very, very, very wide scope, so I could find more things that I could help Michelle to do better with. And nowadays, we don't do that. We treat to target. So, what is she coming in for? She says, I'm depressed and I can't focus at work. Okay. You're depressed, you can't focus at work. I'm not going to ask her about her 5-year-old spanking. And that's not going to make much difference to me in the way I do this. But we're going to work on her depressive symptoms that affect her work life. And it may turn out to be that I give her cognitive behavioral treatment. It may turn out to be that I give her an SSRI. for 3 months and see if I can reduce that depression, and monitor that with the PHQ-9 along the next 12 weeks and see if her work life improves. And if it starts to improve at 6 weeks, I know I'm on track. You see the treat to target approach? It is more of an episode of care that we see. She may want an episode of care later on with me about the 5-year-old time when she was spanked, but that's not the reason why she came in. I'm also going to say it's disengaging with the client. We use that term again, Dennis. It's disengaging when I do go there with her because that's not why she came in. That's what we've heard from clients over the years is, why are you asking me those kind of questions? Why is that important? I came because I got this problem. You know, what don't y'all understand? I used to see those on the client surveys, the patient surveys we did. Didn't really know what to do with them at that time. I was young. That was 20 years ago. Now I know a little bit more about what to do with them. And don't forget, produce outcomes. We've got to engage the clients in natural supports. That's another thing. It's beyond the professional services. Engage people in their community and natural supports, helping clients to self-manage their wellness and recovery. So there's some behavioral activation that's coming about in the treatment that we do now. You want to behaviorally activate people so that they can self-do some of this. And we want to greatly reduce the need for the disruptive and high-cost services because a payer is watching it and a payer is interested. And sometimes payers will just cut you out if you're actually too high cost. And I tell you, we're doing some of those comparisons right now in my center. I can tell between this dentist and this Alina, I can tell what kind of outcomes both of them are doing by looking at paid claims. I can tell if it takes Dennis longer than Elena to treat the same disorder. I can look and see if his adherence rate with his clients is better than hers. I can tell those kind of things now from a payer perspective. And so when I'm going and shopping with my contracts, I'm going and I'm changing that up. So if Alina is performing better and really delivering better outcomes, I go to her and I say, can you do 500 more? Because I'm going to have a message to this dentist that he might not like to hear come the next time the contract rolls up. So greatly reducing the need for the high-cost services. Yes,
sorry, I'm going to be your opinion on that all day. Are you also in the ostensibly behavioral health setting going to screen her for a thyroid problem, menopausal symptoms, etc.? Because if all your problem is focus at work, you very well may not be clinically depressed.
Right, exactly.
And so that's, I mean,
I was thinking about the S-Bird for the physical side.
Right,
and
is
the
there
health
that
professional.
Yeah,
that's the piece I think.
Exactly. Well, since we're talking about integrated healthcare, I was making the assumption we were all on the same page with that, and I was using that mostly as an example that I was exaggerating to do a treat to target. Absolutely, that's important. It's necessary. Those other things have to be done. I'm already assuming that I'm working with her doctor already, and we're in collaboration with this, and there is other work being done with her in this integrated setting. So yes. Thank you for bringing that up.
Yeah, but if she's one of those 95% of our behavioral health clients who doesn't have a primary care physician to have a communication with yet, the question is, are we screening?
Right.
I mean, we're treating the target. We must be maybe treating the wrong target if we are not looking at what's physically.
This is about whole person team-based care.
Okay. Thank you.
Yeah, whole person team-based care. Yes, sir.
I guess along with that, there's a parallel conversation, a parallel narrative that is developing and we're nurturing in the Kansas City area, which is trauma-informed care.
Yes.
And the challenge is how to know when to focus on episodic trauma versus developmental trauma. And integrating those streams into what you're just saying, I think is a nice challenge.
Yes.
It's just around the corner. I mean, it'll take quite a bit of work, but it's an understanding that's also going to change your mind.
Certainly is. That is underlying all of it. It needs to be considered. I bet you guys are smart enough to be able to weave that in.
I think we
I think there's a lot of smart people in this room that can really do that. So, well, I also brought a little bit of data for you that may help if you need to do a business case, analysis for this or something. I wanted just to show you what the cost is for treatment and for these types of services when you have co-occurring physical health conditions. So this is just a slide about comorbid depression and medical expenditures. What you'll see is that on the green bar, the cost of these illnesses rises when you have a level of depression compared to without depression. Just to simply put, you add depression to any physical health condition and it will cost more to treat. It doesn't surprise you, I'm sure, but when you look at the numbers and you think about the cost of health care and that all of us are paying with tax money for Medicare and Medicaid, and through our insurance premiums, we're paying for the commercial health plans. So when we see the cost rise up and we're a part of that, then we know that, again, the intervention, trauma-informed, integrated health care with depression and physical health medicine, the collaboration, finding the sweet spot seems to be one of the answers. But you'll see nearly twofold of the cost in there. One other example. This one is the coordination of care can reduce the cost of behavioral health care. This is my friend Ben Drush. You'll probably know him out in the state of Colorado. Very famous researcher on integrated health care. I've had the fortune of doing a lot of work with him, and it's very nice. And he has done a lot of work on the outcomes of the coordination. This is why we've got to pay for the coordination of care in different ways. But just like Dennis was telling us a while ago, if it's strictly fee-for-service and you get an hourly cost or you get an hourly payment for this, there is no additional money after I've squeezed all the rates down 3 times in the last year. There's no additional money for care coordination and case management and all those things that are the fillers, the tracking, the navigation, those things that make this successful. Sue mentioned the same thing a while ago. This is the justification for why we got to pay for it. And the way to pay for it is these alternative payment structures and a PNPM and an episode of care model, something like that, where you factor in the cost of doing that. So the bottom line here, you add care coordination and case management, you reduce the cost of the care for people that have these types of dual disorders. So what you'll see here again is a year 1 and year 2 for patients with serious and persistent mental illnesses receiving medical care management intervention versus usual care. So what you see is in year 2, you start to see the difference. And this gentleman in quality management over here and I were talking about why that in the state of Missouri that the high-cost patients were selected first in the health homes. Remember that example he gave about the percentage? It was only affecting like 20% of the Medicaid population in the health homes now in the state of Missouri. This is the reason why that they chose that 20%. Because the most seriously ill are the most costly, and the most seriously ill, when you add this kind of intervention to them, and by year 2, it starts to reduce the cost. So the impactability is significant with this population. We're finding that it's impactful in the other populations as well, people that are less seriously ill, but this is a big one. Because if you trim off 15% of a high-cost patient, you have really made a lot of difference financially in that. Here's another example. The big 5 of the chronic health conditions that take people's lives. Asthma, COPD, congestive heart failure, coronary heart disease, diabetes, and hypertension. What happens to these when all these chronic health conditions, when you add mental health to the mix? Look at the blue bar. That's mental illness and drug and alcohol addiction. And look at the light blue, Carolina blue bar, as Scott would say, is mental illness and no drug or alcohol. And you will see that compared to the red with no mental illness and no drug and alcohol, that the cost, again, is lower for that population than it is for these others when you add alcohol and drug use and mental illness. The cost goes up. No surprises to you, but here's an example where you can see the dollars and cents. So I'm sure that everybody already understood that. But I think what's so significant about this is that in every case, when you have mental illness and substance use, and you add these chronic health conditions, you have an appreciably, not just a minimal amount, but a significantly increasing cost. Once again, the reason why the state of Missouri chose that top 20%, this is that population. That's the one they're going after because of these chronic health conditions. That you have to do this in a collaborative way.
Can I ask, this just
Sure.
talks about the Medicaid only, so is there similar research for commercial insurance? Do they have something that parallels that pretty closely?
I don't have any. That's a great question. The public payers have spent a lot of effort in doing this because they're just so big and they're national, and I think that they believe they can save so much money. The commercial insurance, if they do it, they must do it internally. They might not want us to know about, what these outcomes are. But you would think that they would have the same initiative. If the data would show the same thing for Blue Cross and Blue Shield of Kansas, then they would think we need to do something with this population because this is the population that's breaking the backs of our insurance companies. But also, it's the reason why that our health premiums continue to go up in single or double digits every year for the same reason. So, but this magnifies the cost for you. I hope it's shining that light on why we got to manage costs. Here's the disproportionate burden of health conditions and risk among those with poor mental health. So the question was asked, this is in the state of New York, if you have serious psychological distress or non-serious psychological distress on these 5 measures, if your health fair or poor, if you're a smoker, obesity, high blood pressure, or diabetes, how does the presence of the serious psychological distress affect this particular either lifestyle or this particular illness? And you'll see that in each of those examples that it increases the prevalence of that. And the same thing here. This is the question in the same population asking about the accessibility of medical care. This is not a surprise, we've already talked about it. When people have mental health conditions, they are less likely to be able to access medical care, and this is another one of those examples of that. This slide tells you more about the Medicaid population again, but it takes those dimensions of hypertension, heart disease, asthma, COPD, substance use, it adds that to it, diabetes, arthritis, a developmental disability, a stroke, cancer, and dementia or delirium on the bottom axis. And it tracks the prevalence of the comorbidities of mental health Medicaid beneficiaries and the cost associated with that. So this is the data that the managed behavioral health organizations look at when they're managing Medicaid. This is what I look at. So I look at that and I say, wow, in every one of these examples, when you add mental health, and the mental health beneficiary in Medicaid is one billed claim in a 12-month period of time. For a psychologist, a therapist, a psychiatric nurse, a psychiatrist, an ACT team, whatever the case may be, one billed claim is my trigger, and I can data mine that, and I go into the Medicaid global eligibility file with 1.6 million covered lives in North Carolina. And I can tell how many and who it is. I can drill right down to the patient. I can tell you what they received, what service they received, and how much that cost. So when we look at mental health beneficiaries, we know that on these dimensions, they all have a higher prevalence of the comorbidity of these particular illnesses than the non-mental health beneficiaries. So mental health is seen now as correlating with a higher prevalence of these illnesses, a very significant factor. This one is about co-occurring disorders among Medicaid beneficiaries now with substance use. So the first one is mental illness, this one is substance use. And you'll see in almost every case, not every case, stroke is different, also arthritis is different, and the cancer is different. But in every other example, the substance abuse Medicaid beneficiaries have a greater prevalence of these physical health conditions. Okay? So, you don't have to, after all that, I'm sure you could, everybody, if I said, what does mental illness do to diabetes, you'd say it makes it worse. Well, it actually does. And of course, it's not just the diabetes, but people with depression have an increased rate of all adverse health outcomes. Mortality, cardiac events, hospitalizations, diabetes-related complications, functional impairment, and quality of life. So, kind of the moral of this slide right here, in an integrated setting in primary care, if we treated mild to moderate depression when it's prevalent, if we did that, we would appreciably impact not only the level of depression that the patients have in this primary care practice, but we would also reduce the overall cost of the health care that they need. And we'd make happier patients. But we ignore it. you know, and I'm not accusing, I'm saying that I'm a part of that system. We have historically ignored the depression that people have brought to us in primary health care because we've not seen it as integrated. We've not seen it as something that we need to do something with. But these are all the potential benefits. People can achieve greater functionality in their life, the quality of life. Just yesterday, working with several teams here in Kansas City, I tried to make this point that sometimes in medical health care, we don't always think mental health and why that's a problem. So I'm going to give you an example. So, and this is something that is real life in my life frequently when I'm working with primary care doctors. They'll say, you know, well, David, one of these big problems we have is that we can't get the patients to adhere to the treatment that we put on the treatment plan. You know, we can't get them to take all their antibiotics. We can't get them to take their medicine. We can't get them to do this. We can't get them to stop smoking. We can't get them to do a lot of things. And I just asked the question: could there be a mental health condition that's getting in their way? And you just let it rest. When you do that, you let it think. And they start to think, you know, could a depression keep me from taking my medication? Because I'm lethargic and I'm not too excited about getting up in the morning, and I'm having a hard time focusing at work and with all the children care and all the other stuff going on. And I watch TV and it bothers me about all the chaos going on in the town or the city or the nation or the world, and I get more depressed. And I just don't find life, you know, that leads me to take this medicine. I don't really feel that much different when I do take it. So therefore, I'm just going to stop, or I'm going to take it every time I feel like it. You know, that's what people do, and the medical doctors will say, "Well, you know, we really never thought about that. We haven't thought about the mental illness interaction there." But note that happens. I've already mentioned this. When you ask primary care physicians how can they access mental health or how that goes, most of them say that they have a difficult time accessing mental health. And here's one of the studies that shows that. 67% in this study said, we just can't get people help for mental health conditions. So I don't think anybody in the study said we ought to do it internally. They were trying to refer people out. And that's the problem with referring people out, is that people don't make the connection. It's very hard to get people in. And again, you'll see some of the top reasons why that primary care physicians cannot get mental health services in, maybe a lack of adequate coverage, health plan barriers, or a shortage of providers. And I think when you say shortage of providers, that's their interpretation of we actually refer, but they can't work them in time, so it's a capacity problem. And it may be a capacity problem because Eric's no-show rate is 40%, so nearly half of all of his activity is just an unfilled time. So kind of in a global perspective again, just the key components of things we've talked about. There's a prevention and there's an early intervention kind of concept that we need to pay attention to. There's this integrated horizontal care delivery system with primary and behavioral health care. There's accountable care organizations that will come in also in our states and will be accountable for the whole outcome of care and will form big systems that we need to be able to play with. We need to be able to interact with, and we need to have a value added for them. There's medical homes and healthcare homes, which we've been talking about today, which have integration. And we talked about payment reform again, primarily shared risk models that help us to achieve some of these goals. You'll see in the Affordable Care Act, you'll see 5 different tools. We talked about most all of them. The only ones we haven't addressed today are the number 4, number 5, the federally qualified health centers and multi-agency health homes. All of these have integration as its foundation as well. So I encourage you, if you're involved with some of those or if you're working with some of those, then this still applies to you. You are one of the tools and you represent one of the tools.
I'm just curious, I'm not familiar with multi-agency health homes. Is that more like a co-op of?
Thank you. Yes, good question. Yeah, it actually involves the social services and kind of public health and different ancillary type services that you might bring together around the health home. So it's broader. It approaches really a health home type of neighborhood, but health home neighborhoods are more involved with specialties. You're getting actual specialists in there. So this has the behavioral and social services, housing supports, day programs, all types of different supports. It's one of those places that people find really good at transitioning to self-help and self-directed care on their own after they leave professional care.
Okay, so the key elements of social services, that's
Yes.
in addition.
That's correct. Thanks for asking that. Yeah.
David, it's largely a co-location of, you may have your primary, maybe it's the CMHC or maybe it's the FQHC, but you've also got everybody else around in there.
Right.
A couple of years ago, we tried to do that for the homeless with the Margaret Kemp Center downtown, where we were going to put everything right in that same block.
A one-stop shop.
Yeah, it's a one-stop shop, but not one, it's not Walmart, it's Walmart with Starbucks on the outside and, 15 other organizations.
Yeah, there's all types of things there, sort of the cafeteria.
It's a health mall. It's a health mall, beautiful.
Yeah, that's right.
It's a health mall, anchored by Walmart.
And also, just to say a little bit more about the community behavioral health homes, these are the specialty behavioral health clinics that then provide health home type services. So usually for the seriously or the severely ill on the behavioral health side, but they need primary care too. We want, again, because they have barriers to getting access to primary health care. We want to make sure they get it. So there are some elements that affect that as well. So here's some challenges. So now these are the challenges that you will face as you go through life trying to integrate. And so I want to encourage you to think about how you'll overcome these challenges. Number one on this list is that there's oftentimes when you start up these integrated practices, there's a low level of cross referrals that go over. So if you open up a community behavioral health organization with primary health care, what you'll find is that the primary health care side is going to be slow to come up. In other words, there'll be fewer people than you expect that will be wanting to get engaged with that, and vice versa. If you are in primary health care and you bring behavioral health, you'll find that the early days will be very few types of referrals over to your behavioral health care consultation opportunities, because that is history. This is new, and you need to educate this setting that you're in. So there needs to be some cross training. That's the motto here. I don't want you to forget that we need to train people in how to do it, so that they really don't forget that there's an option there. And another area, we had a really nice health home startup, and it was in a mental health center, so it was primarily for the severely mentally ill, and a lot of those people did not have access to good health care. So it was a great opportunity. And after about several months, I got a phone call from the center, and they said, "Well, we got this problem. Would you come back out and take a look at it?" So I said, "Yeah, tell me more about this problem." The problem is that the nurse practitioner they had hired was only seeing like 2 or 3 patients per day. And we built a model on that nurse practitioner seeing 13 to 17 patients a day. So it was not sustainable the way it was going, because it wasn't working well. So when I got there, I found that the patient flows had not been clearly mapped out, and also the culture had not changed within the organization to be that everybody was on the same page with a general education about what we're doing. So the mission had not changed, the vision had not changed, the paraphernalia around in the waiting room had not become integrated care. It was still a mental health center with a little box over here with a doctor in it, And if you happen to get lucky enough to get into that door, you got some primary health care. But if you didn't, then you didn't get it. And so we had to reorient the patient flow, and we had to educate the staff on how to use that. So don't forget there's an education there. The clinical focus also with behaviorally trained clinical team members is primarily on identifying and addressing the signs of mental health problems. And unfortunately, that's not the medical side. So we need to train, on the mental health side, we need to train them in physical medicine signs and symptoms. So for example, some of the must-dos whenever I go out are lab values. We need all the mental health professionals to know what normal and abnormal lab values are for about 6 or 10 of the basic lab tests. And we need to teach them that. For example, what does an A1C mean? And what is normal and what's abnormal? What is normal blood glucose? What is the normal range of hypertension or blood pressure? What is the margins? They need to know that. because as they work with the clientele, they can identify for the healthcare providers when something's not going right. Now, on the physical health side, they need to know some things too. They need to know about how to detect depression, what that looks like. They need to know signs and symptoms. We all know, because we're mental health professionals around here, that children exhibit depressive symptoms differently than adults, right? We know that's different. But not everybody knows that. So we have a role to play in educating the mental health type symptoms. Just as the example I gave you a while ago, if someone's medication non-compliant with a physical health condition, could it be that depression is getting in the way? Cancer patients and heart failure patients are predominantly in this population. They, because of their chronic nature of their condition, they develop levels of depression. And the levels of depression often get in the way of their compliance with their health care. And if no one pays attention to that, and no one says, I wonder about that. In fact, at a transplant center at Wake Forest University, down where I live in North Carolina, when people have organ transplants there, they automatically get mental health services. It is a normal protocol every single day. Well, I think that's amazing, you know, that we recognize that people, that they might, if they don't need it after the first visit, they don't need it. But a lot of people do. And it was the recognition that more often than not, we ought to be looking at that. So, Eric?
It seems to me this not knowing across disciplines starts pretty early in one's career. So have you seen any, around the country, any universities move to merge their schools of social work or counseling with their medical schools?
Yes. I wouldn't say merge in the medical school, but I'm saying across population. In fact, I am doing some of that at Wake Forest. I am teaching internal medicine residents motivational interviewing. And, you know, and the whole thing is sort of an expert type thing, you know, teaching that. And they say, wow, and I teach it around, you know, like how to get people to do lifestyle changes, you know, like exercise, weight loss, smoking, all that kind of thing, you know. Let's use motivational interviewing to help them to interact with their patients. And you know what they say after they finish a half a day's worth of that? They say, you know, I bet you could use this for people that don't take their antibiotic, you know, for the full 10 days. Aha! something caught in their brain, and it was good. It was good. So yes, we're seeing a blending of that more so than not. I think also the integrated crossovers are becoming more prominent in medical school education. So.
Yeah, I'm pretty sure with the KU nursing program now, psychiatric nursing is not a separate rotation. It's integrated with all the different rotations, you know, pediatrics, adult, you know, integrated as they go. So that's kind of exciting.
Yeah, very exciting. I think another thing that will be an opportunity and a challenge too is the whole team-based approach. A fully integrated clinical team, which is this next one. And so, you know, how do I see myself working with a team? If I feel like I'm at the top of my game and I know a whole lot of stuff, why do I want to be affiliated with a team, and why do I think I need a team? It may make me feel inferior. Well, I got to get over that. You know, because that's not where this is going to go. So helping the professionals understand that this is a team-based approach. This is harder for primary care doctors than it is for the mental health people, I found. Primary care doctors are trained to be like emergency room physicians. They really do a lot of things. They have a wide scope of expertise. They're dealing, in a single day, they're dealing with a nosebleed, they're dealing with the flu, they're dealing with GI problems, and they're dealing with post-heart attack victims. You know, they've got a lot of things going on. And so, and they're taught to be very self-sufficient. And so seeing it as a team approach is oftentimes a challenge, and we have to keep reminding them about that. Also, the workflows need to be incorporated, need to have processes that ensure that the wellness needs of the individuals that are recipients are paid attention to. So in your protocol and in your workflow, make sure that there's wellness and disease management. Again, we're trying to behaviorally activate people. We're trying to make them less dependent on professionals. Remember my true confession? 30 years ago, I wanted, who did I use as an example? I forgot who. I'll just use Michelle right now. Yes, I think it was you. Yeah, I wanted her to become dependent on me. She needs me. The only way I felt validated in my professional work is that because she wanted to come see me for 3 or 4 years every week. This was, you know, she needed me. And only until she didn't need me when we can separate. And that is a very dysfunctional type of way of doing this business now. We need to help the systems to develop these processes so that actually Michelle learns how to self-manage her own illness. And I am there as a temporary professional to help her to get to that point. And so there's an outcome right there. When she is starting to self-manage, then we have achieved an outcome that can be very helpful. There's two types of these behavioral health care homes with primary health care embedded within them. Or I guess two types of involvements. And that's where you participate in the development and the deployment of this bidirectional integrated care, or you become a health home neighbor. And what I was doing yesterday with Truman Medical Center and the Heartland Center is to help them to form a health home neighborhood of a lot of different professionals and services, so that when the client enters, no matter where they enter, no wrong door, they will get all of the services that they need. So it's sort of what you were talking about, Sue, that mall version. It doesn't really have to be co-located as much, just that it has to be coordinated and networked. It's great if it's co-located, but it's even, but it can actually work if it's coordinated and if it's case managed all together. So those are the two ways that looks like there. Now, some of you might be familiar with the Substance Abuse Mental Health Services Administration, a federal arm of the government that leads around healthcare initiatives. Several years ago, they released a letter to all the Medicaid agencies. So it was what we call the Dear Medicaid letter, and if you all know what that is, I think the federal government sends about 4 of those Dear Medicaid letters out every year to the Medicaid directors. So it goes to all 50 states. This one, I think, was 2011, and it said, look, we're going to redefine this for everybody. The modern mental health and addiction system is what this is called. We're going to tell you what the modern mental health addiction system is about, and we're going to give you 9 domains and 11 service groups that we want you to deploy in all 50 states for your Medicaid population. So if you've ever wondered where some of these things come from, this was even before the Affordable Care Act. So I just wanted you to see these 9 domains for the modern addiction and mental health service system. You see it has health homes front and center at the top left. Prevention and wellness, engagement, outpatient and medication-assisted treatment. They're talking about addiction there. Community supports and recovery services. Here's the things that Michelle is going to do when she graduates from me. She's going to become self-sufficient in her own recovery program. Intensive support services, other living supports, out-of-home residential, and acute intensive services. You see the full array right there. So 9 different domains are defined in the modern system. Then they identified 11 of these service categories. And I've got them for you in these 11 kind of columns. Notice the first one that comes from Samson. Healthcare homes with physical health. The upper left. I know they're small in your handout. I apologize for that. By the way, you can go to the SAMHSA.gov. You can get all this. So if it's way too small and you want to see bigger versions, or if you want to use it some other way, go over there. But you'll see. Look, dentistry engagement services is the third column. You know, this is what the government was saying. Some smart people got together and said, you know, we're going to redefine what healthcare is about and say, for the modern addiction and mental health service system, what needs to be in the quiver of that service array? These are the first 5. You see outpatient and medication services over to the right. These are the next 6. Community support, other supports, intensive support services, out-of-home residential, acute intensive, and again, recovery supports. Again, what you see is a big influence on integrated care. You see a big influence on recovery-oriented systems of care. And you see a big influence also from the standpoint of self-direction. A lot of self-participation and activation. I'm sure a lot of you know the 4-quadrant model, and I won't spend a lot of time on this one, but just to note that there's a 4-quadrant model for mental health and for substance use. I like this because it allows me to talk to people in the same ways, and it fits the bidirectional model. I just want to point out how that does that. So when we talk about the 4-quadrant model, I can group clients, and I can stratify clients into 4 different categories. And so in my mind, I do one single dividing line in my mind because I'm a simple, slow learner. So I've got quadrants 1 and quadrants 3. Quadrant 1 and quadrant 3 are low mental health need, but either low or high physical health, that's in quadrant 3, that patient can be served best in a primary care environment with some integrated behavioral health care. Then there's quadrants 2 and 4. 2 and 4 are high mental health with either low physical or high physical. Quadrant 4 being high mental health and high physical. Those people need to be served in specialty behavioral health clinics with integrated primary health care. So you see the stratification. So I can come along and I can divide the line and we can ask questions. So if someone's got a severe mental illness and they've got a chronic health condition like diabetes, they're over in quadrant 4. That's just how my mind goes. If someone is an at-risk drinker, what we talked about with Esper a while ago, if they're an at-risk drinker like Eric on last Sunday at the race, so he's at-risk drinking, then he might be at quadrant 1 because he's at risk doing something that could lead to something bigger, but he also has no big physical health conditions yet. So he can be served best in a primary care environment. That's just the two extremes. That's why I like this. The other way, the other strategy or the other rationale for using this is that in each of the quadrants you'll see an array of services, a menu of services that again correspond to the modern addiction mental health treatment system in the United States. And you'll find what you normally would have to treat people within the quadrants 1 through 4. This is the one for substance use. And again, you can go on the National Council website and get bigger versions of these. And you'll actually see, I've actually cited it right over there for the, so just go to the National Council website if you want to do something bigger. This is just a picture again of this bidirectional care model with primary health care and the community behavioral health care operations being one and the same. So notice that in the text you'll see the clinical design for adults with low to moderate and youth low to high behavioral health risk and compatibility on the left. So in that picture, what we're talking about is that's our primary care clinic with behavioral health clinicians that are embedded providing the assessments and the person-centered planning and consultation, care management, and direct service. And they've got a partnership linkage with a specialty behavioral health organization when they need that. And over on the right, you'll see the clinical design for adults with moderate to high risk using the 4 quadrants. Again, quadrants 2 and 4 on the right-hand side, where this is the behavioral health organization with an embedded primary care focus in there. So, I've told the team yesterday, there's the David Letterman top 10, and there's the David Swann top 10. This is the David Swann top 10 of the key delivery challenges. This is what you're going to have to face in all of these things. So you've got to decide what model of integration you're going to have. So that's one of the basic things. What model that you're really going to do this in. What partnerships do you need? Who do you need to do this with you? How do you use the 4 quadrant model? Do you use it like I just described, or use it some other way? How to prioritize the clients for primary care. Again, go back to what the gentleman agreed to over there. This is what the state of Missouri did. They prioritized the top 20% of the Medicaid population because of their health, risk, and costs. And it's sad that they had to do that, but they had to do it. Somebody, it was where is the greatest ability to impact the population? You go for the high cost, high utilizer. I was actually telling him at the break, my goal would be, don't stop there. This is a developmental model, so you need to bring it down so you get to the 100%, but you start with 20%, but you've got to decide how you're going to prioritize. So if you were a mental health clinic today, and I was helping you to bring in primary health care, I would say, how many people do you serve? And you say you got 5,000 clients. And I say, okay, here's what we need to do. Let's look at your electronic health records, and let's determine if you're already asking some good questions that would help you to detect whether people have chronic health conditions. And let's say that you do. So therefore, we might go in and stratify the population, and the first cut would be anybody with 5 or more chronic health conditions, pop them out of the computer. Make the list of names. We find there's 125 of those. That they got 5+ chronic health conditions, some of the big ones. Start right there with primary health care. So there's the first 125 you got to work in. Then you take the next layer. After you get that done, then you go to the next layer. What's the 3 to 5 chronic health conditions associated with the mental health condition? And essentially, you're prioritizing, you're stratifying your risk for those clients. The fifth thing that you'll have to decide to do is what if you're behavioral health care and you're integrating primary health care, what are the primary care services that you will integrate? What are those things? For example, a big one that I want to encourage you to think about, but a lot of people don't want to do, is acute physical health medicine. So when someone comes in and they've got a cold, the flu, whatever that case may be, you really want them to get their care for that, because that's early on intervention for some later on serious physical health consequences. But sometimes the behavioral health providers want to start off at just doing the detections, doing the tests. We want to do BP, we want to do temp, we want to do height and weight, we want to do those kind of things. We want to monitor, but we don't want to really treat for acute illnesses. And we certainly don't want to have to case coordinate for chronic illness. See, and I say, well, you're really shortchanging your clients again, because if they don't have good access, they're probably not going to get any better access other than some of the testing that you're going to be doing. So you got to figure out what are the services. Screening for chronic conditions for all persons, for example, on psychotropic medications is a good low-hanging fruit. Anybody on oral or atypical injectable antipsychotics ought to be tested for metabolic syndrome. They ought to be tested 4 times a year. In fact, in the clinical protocols that I put in, I usually say, you know, based on your stratification, you can tell how frequently people need to be coming in, and you can set your schedules that way. What office and support structures need to be in place for effective integration, and how will you address medical records, integration, and access? That's number 7. There are 3 more. What billing and code changes will need to be, will you actually need to be used to make this work? How will care management and care coordination be provided for persons? Again, we can't forget that. Sue reminded us a while ago, that's what fills in the cracks. A fee-for-service system that Dennis and I were just working on a while ago will not deliver the kind of outcomes we're talking about without the care management and the care coordination. And we've got to have the new payment structures to afford that. The fee-for-service we're paying today will not make that work. And how you will integrate the wellness and disease management, again, to help people to become self-actualized with that. So, you know, questions that you need to ask yourself are, you know, what level of integration fits your community's needs? So even beyond your practice, but think about the whole community of where you work and live. If you're at Truman Medical Center, I don't know if you're at the Lakewood place. I was down at the Lakewood. I was actually down there on Sunday afternoon with some friends of mine, just because I was interested, because I'm working with Truman, and I said, I know one of those hospitals is nearby where I'm at. And they said, yeah, we'll drive you right down the road. They're out by the lake in Lee Summit. Yes. Beautiful place, yeah. And so you think about, well, what fits out here? You know, what fits in the culture? Look at that. And there are 6 levels of integration, and I don't have them for you today, because it would just get too long. But you can look that up, or you can write me and ask me, and I'll be happy to send those to you. But it goes everything from, you know, we're kind of thinking about dating, to we have a first date, till we go on and we get married. I mean, there's everything from A to Z in those 6 levels, but that's essentially what that means. The practice culture. Do not forget this. If you don't modify the culture, this will not work. You've got to have an all-inclusive, team-based practice culture. So if you can't get me on board with that, then that's going to be a problem, and you might need to move me out in order to change that culture. Again, what the services that you want to deliver, work in patient flow, the collaboration with other medical specialties, and sustainability. And we'll talk about sustainability in just a minute. So how do these things look? These are person-centered health hubs. So they're around a person. They're centric to the patient. I know that's a novel idea. We probably talk about that a lot, but we sometimes don't act like it. So when I was thrilled with the no-show 30 years ago, that's not patient-centered. Let me just point out my faults, you know, for a minute. I know none of you have any of those. So did you raise your hand? Okay. None of you have any faults, I know, but I actually did. I turned around in my ways, though. I'm a lot better now than I was. The culture and practice styles. You have to adapt to this. This is awkward also. It's awkward to bring primary care into behavioral health. It's awkward to bring behavioral health into primary care. What do we know about primary care is they move fast. It's a fast-paced environment. You know, seeing everybody 6 to 8 minutes and blah, blah, blah. By the way, the doctor moves to each room where the patient is, right? Well, what about in a mental health integrated, in a primary care practice where mental health is integrated? What about the therapist moving from room to room so that you can be quicker about that? Interesting idea, and it works. It works in places. Roles in the wellness and disease management. Again, I don't want you to forget that. That's what they'll look like. There are some joint principles. I want to point out some principles of patient-centered medical homes. This has been adopted by all these great things up there, the American Academy of Family Practice, the American Academy of Pediatrics, and so on and so on. That this is all about everybody needs a personal physician, and when I say personal physician, I'm talking about it could be a mid-level practitioner or it could be a physician, but some healthcare provider, because that's what we're trying to deal with. For mental health clients, they need primary care. It's physician-directed in medical practices. And so if you're in a medical practice, your behavioral health work needs to be directed around that medical care. It's got a whole person orientation. Bobby reminded us about that earlier. The care is coordinated and integrated. Quality and safety are hallmarks. And there's an enhanced access and payment reform. So all of those things are key principles of this patient-centered medical home, and that's where the standards find their formation of that.
Yeah. On the payment form, are you referencing like same-day billing and CPT codes of how those are going to be reformed?
That could be, but when I'm talking about payment reform today, I'm mostly talking about those pay-for-performance and value-based purchasing options. So what you really want to see happen is a change from today's care to tomorrow's care on the right. I'm not going to go through each of these, but let's pick out a couple and just kind of look at what that's like. So look at, let me go up closer and I'll point here. So I'll probably have a pointer, yeah. Look at this. So care is determined by today's problem and the time available today. So I don't have any time for you today, or I have only 5 minutes, so I can only do so much. Versus the care is decided on the right over there by the patient goals. See how self-directed that is? Patients now start to say something. Look at this over here. Patients are responsible for coordinating their own care. Now, how many of you have gone to your primary care doctor and got a referral to a specialist, and if you didn't show up, and if you didn't get there, and if you didn't do all the things, you would never have gotten to that specialist? And over here, a team of professionals coordinates all the patient's care to ensure that it's integrated and working. How many times for my elderly mother have I gone to get medical records from one practitioner to take them to another? Because they didn't know how to do it, they didn't have the capacity to do it, or they just wouldn't do it. But I knew it was critical to the care.
I was going to mention that my wife is going through that with her dad. He's older, but she's like doing the MI with him because he doesn't want to go do stuff. There's no one on the Medicaid side that's pushing him right now. It's my wife that's doing that on a regular basis.
Oftentimes families are doing this, but in this model, we're suggesting that other people be accountable for it. Again, it goes right back to the accountability of this. Look at this one. It's up to the patient to tell us what happened to them versus we track tests and consultations and follow-up after the emergency department and hospital visits. Isn't that a novel idea? Amazing. And of course, underpinning all that is great information technology to communicate for that. So here's what they usually have in them. This is what usually is contained in a behavioral health patient-centered medical home, where you're serving people with significant mental illnesses or mental health or IDD or substance use conditions. You'll see a lot of preventative screening. You'll see the acute primary care that I mentioned earlier. You'll see women's health. Women often go to mental health services more often than men do. And so therefore women's health is important. They don't get good access, but they have mental health conditions, so women's health needs to be a part of that. Management of chronic health conditions, so not only is it acute, but it's also managed of the big things like diabetes, maybe heart disease, other things. And also these providers need to have access to labs, x-ray, medical surgical specialties, and hospital care. It's ideal, as Sue would say, if it's in the mall, great. But if it's not in the mall, you've got to have it connected like a hub and spokes. It's got to be connected and easy to access for people. And the care coordination has to make that happen, not the patient's responsibility as in the old day care. Here's a little bit about the culture of these integrated practices that we're going in now, from behavioral health going into integrated care or going into primary health care. Again, it's fast-paced. I would suggest, and mostly the practices that I set up, they think of this as a consultative mental health service because it's not long-term care, it's consultative. There's high volumes of people seen, so the average behaviorist that I put into an integrated care, primary care practice might see 9 to 13 people a day in 20 to 30 minute short, brief interventions. They'll see them no more than 5 or 6 sessions, and then it's over. And so when they first see someone, if they determine that they need more than that, they're going to be referring them down the street to the specialty behavioral health operation with the embedded primary care clinic inside of it. And when that happens, we're going to care coordinate that person down there, but they'll get their whole person care down the street rather than up here. Remember the bidirectional approach. So at both ends, you can identify people that need to be on the other side, and then you care manage them down to this side. You want immediate access and availability and visibility, or interruptions are okay. I can describe this for you, and I want to get you ask me some questions in a minute, but let me just describe that a little bit because I want to make sure you understand. These types of behavioral health consultations are most often planned. They're scheduled, but there's a lot of times when Terry, who is the primary care doctor down the hallway, needs to get me to come in with a patient with her and do a 3-minute engagement so that a person doesn't leave the building. So she comes down and knocks on the door. Now, I've been seeing Ed for 3 times, and I told Ed on the first visit, you know, Ed, if Dr. Terry comes down and she knocks on the door, she needs me down the hallway, and I'm going to disappear for 3 minutes. I'm going to go down and help her for a minute, but I promise you I'm coming back, and we're going to pick right up where we left off. This is not my grandmother's mental health center when I'm doing this, is it? This is not the way I learned 35 years ago in school in the 70s. I learned the hour was sacred. Thou shalt not interrupt me. You know, that is not the thing to do. And sometimes I need 90 minutes, and sometimes I need 2 hours because I'm treating Michelle for 4 years, you know, and we like each other. And so, you know, she's dependent on me. So what we're doing is that we're making this fast paced and we're making ourselves available. So what I would have lost in that encounter is I might have lost a client. We might have lost somebody that we're accountable for our system if I didn't go down with Terry and engage that person. Here's what I do in that encounter. I go down there, and Dennis is down there with her, and I say, "Hi, Dennis. I'm David Swann. I'm the I don't use the word mental health in this sentence. I'm the behavioral health consultant for Terry's primary care practice. She just brought me down here to chat with you just for a minute. I know you've got some things you want to talk to me about. You see the motivational interview coming out. I know that I'm going to draw it out of you. I know you've got some things you want to talk to me about. But I'm with Ed right now. I won't say his name, of course. I'm with somebody else down the hallway. I tell you what, after you finish with Dr. Terry, she's going to let you sit in the waiting room, and I'm going to come out and get you. We'll have a few minutes. We'll have a short period of time, whatever we can take. But I'm going to try to engage you even further in what we can do with you. If it turns into something that's 15 minutes, it's billable nowadays. If it's not, then it's not. Therefore, again, you have to have PMPMs or some type of episode of care to cover some of this cost. When the new CPT codes came out, of course, they took away everything below 15 minutes for us, you know, so you can't bill a psychotherapy code, you know, unless you get to the 16th minute. So my minimum in scheduled time is about 60 minutes, but my average probably is 20 to 30 minutes with patients like you. So, you know, we need to know the new vocabulary, different documentation. But you know, there's a different vocabulary in primary care. We need to understand that. They need to understand us. So there's some training there that needs to take place about the culture. And again, you think about open access and same-day scheduling. Primary care is all about that. Yes, ma'am.
I'm sorry, I just have a quick question.
Yeah.
In this scenario that you just discussed, is that for Medicaid and Medicare patients only?
No.
Only 15 minutes?
No, that is the current procedural terminology code minimum standards to bill and report a psychotherapy code.
Okay.
The rule is that you have to hit the time rule, or have to meet the time rule for CPT, which is published by the American Medical Association, and the minimum amount of psychotherapy time is 15 minutes plus. You have to cross the midpoint at the lowest level code, which is a 30-minute code.
And do you have to close out the primary care visits and open a new encounter for that 15-minute visit with a behavioral health consultant, or can you bundle?
It all depends on your payer.
Okay.
It all depends on your Medicaid state agency if it's Medicaid. In some places you can bundle, some places you can't.
Okay.
Most states now allow you to bill multiple services to Medicaid on the same day. So we used to do the bundling when you couldn't unbundle that, when you couldn't do that. Now that you can do that, most of the time I'm going to answer you and say that the encounters are separate, but I don't want you to mean not coordinated, because they are well coordinated. Yeah. So we are both going to be on the same page, and she's going to see what I'm doing, I'm going to see what she's doing. We're going to get him better. So thanks for asking that. Excellent question. So. Well, just a little bit more about wellness and recovery and all. This is a little cycle that I like to throw up here, if it means anything about what people have with mental illnesses. Let's just address the stigma just for a minute. When people have serious mental illnesses, they're often segregated from our society, and in our general population, they are not really wanted. In fact, many people that I encounter with these kind of illnesses are even told not to come to a primary care practice because they don't want that kind of person in the waiting room. Because they might not smell right, they might not speak right, they might act in different ways, maybe bizarre ways, and it threatens other people and it scares other people. So essentially, as a cycle of recovery moves from left to right, you know, when someone is labeled mentally ill and as they move over to right, they're really trying to reclaim themselves and to reclaim integration. I just like this because I think this is another role for us in integrated healthcare. We would be able to provide that kind of holding environment for these people with serious mental illnesses as they get the right kind of health care and make their own recovery. We're helping them to reclaim their position in society and their ability to engage with society. That's really all that's about. I just thought it was a nice little thing in there. Now, when I talk about the tracking or the monitoring of those key labs or the key healthcare indicators, these are the things that I say are must-dos when you're running a behavioral health organization that integrates primary health care. You always want to know that you're doing glucose testing, you want to do lipids, you want to do BP, and you want to do weight and BMI. Because these things are the ones that detect some of the illnesses that our patients find. These are the 4 minimums. There's a lot of others you might want to do, and I would encourage you to do more than this, but these need to be recorded, tracked, and anybody who's high risk, these need to be tracked more frequently than they would maybe normally be. But I get all this stuff every year like you all do, probably an annual fiscal. But if I took Invega Sustenna, if I took Risperidone Consta, I probably need to have this 4 times a year. That's what you would want to do differently. Just a little bit about the type of personnel that you might like in an integrated behavioral health organization. Nurse practitioners and primary care physicians usually are located, in or on site to provide the primary care. And again, I've written in there about the acute care concerns, prevention, chronic care, all of those, and also the use of the screening tools and that detection. So having a nurse is great in that environment as well if you can afford something like that. So I usually say that you don't need as much primary care doctor time as you need nurse practitioner time. If you do hire nurse practitioners for some of these services, most places do. The average now when I see a launch, it's 1 full-time nurse practitioner and a doctor like 2 days a week. That's kind of what I see. And we actually, if they can actually do that, I say save the doctor time for a higher level stratification of your population. So again, you might draw into the line, 5 or more chronic conditions gets the medical doctor, not the nurse practitioner. If you don't have enough in that population, to go down to 4 or 3. But have the doctor do the more chronically ill people and where there's a lot of risk, and have the nurse practitioner do the lower level folks. And work it out that way, and then allow some time for supervision and consultation. When the nurse practitioner gets in a little bit over their head, maybe they say, this person's got this and this, what do you think? And give me some support and guidance here. So, embedded nurse case managers, nurse care managers, or what Sue was referring to a while ago, is sort of the filling in the cracks. I have a good friend that always says you can always eat ice cream after a big meal because it just fills in the cracks. And these nurse care managers are really the ice cream. They just fill in the cracks. They link it all together. They're monitoring all these lab tests. They're helping with your registry. They're helping to keep up with people. They're making sure that people get the specialty health care when they need it. They are a key part of the team. If you can have these people, these are great advantages. Again, it's hard to afford them on a fee-for-service basis. These have to be done in an outcome-based environment. That's why that I say you cannot do this really on fee for service. Otherwise, you're just doing hourly services, and you're really not going to accomplish some of the outcomes that you need. Providing evidence-based practices is, of course, another thing both on the healthcare side and on the behavioral healthcare side, and then creating wellness programs. So if you'd like to see a workflow in an integrated setting, there's a link on this slide that you can go and put in your computer, just on a web page, and you can go to the National Council and you'll find, it's an algorithm, it's a flow chart of the patient process that I think I did in a Colorado team, I think back in 2011. I just had one little thing about stepped care, because we were talking about targeted or treat to target, and stepped care is another relationship to that. Stepped care fits very well in integrated settings because it starts off with a targeted approach. And basically, as a person moves or makes progress, we adjust the care. Now see, my old true confession again, when I was treating Michelle 30 years ago, for 4 years every week, I didn't really care about changing the treatment plan, because if I changed it, it was a little bit more work, you know, and between those no-shows that I had and calling my wife and catching up with her, I really didn't have enough time to read the treatment plan, so I really didn't want to do that. But stepped care means that you start in each step and you make progress and you adjust the plan as you go. If something is not going, if the progress is not going right, then you adjust the plan. If something's going right, then you might reduce the intensity of services. I might add psychiatry if something's not going right. I might actually take away something if something is going right. In other words, it's the least intensive need for positive results. That works well in these short bursts of treatment that I'm talking about. 30 minutes, 20 minutes, 6 sessions. If that's all you have to go to tools like this to make progress. So treat to target and step care models are what's good. I've given you a little bit of information again about that. There are 4 steps in like a step-tiered model, and I've put them up here for you. And you'll find that this has motivational interviewing as its foundation. It'll have behavioral activation in it, and it has kind of rigid content. But it's an evidence-based practice, and it works again in the short term. So now sustainability, and I think this is where we end up, and I'll see what kind of questions you have. And you're going to have a more intensive about this next time, so Tracy's going to make sure that it happens next month. But this is critical because you can't keep these things going if you can't sustain them. So there's a number of key ingredients you really have to assure that you have adequate referrals. And again, if that patient flow is not working right, if people are not getting into whatever that you started new, then you're going to have difficulty with that. I always say avoid grant funding dependence. I've seen hundreds of these start up with a grant. And when the grant ends, it's over and it stops. But I also encourage you to get grants to get them started. You just don't want to be dependent on them. And because they have to become sustainable. So don't forget to build in that sustainability plan. Just like this team that I described to you a while ago, they actually started off with a grant. They got a grant of $130,000. They hired a full-time nurse practitioner, and they hired a doctor 1 or 2 days a week. And they put those people online, and nobody came. And when they called me, and we worked through the workflow, we figured it out. In fact, this is just what I did with the nurse, with the front desk receptionist. And I was there, I said, so Michelle, have you noticed anybody that came in the last, month or so that might have had physical health illness that you might have just noticed or detected? And she said, oh yeah, people came in and they were sneezing, they had the flu, and they couldn't talk because they had laryngitis, and they looked like they had the stomach bug, and they were talking about all this, and they were doing this kind of things. And I said, so what did you do? And she said, well, I didn't do anything. I said, do you know there's a doctor right behind you that's like 30 feet in another office? And she said, well, I knew he was back there, but I really didn't know what he did. And you can see the patient flow issue and the culture. You've got to change the culture. Michelle has got to know at the front desk that something's different about this practice. And so avoid grant funding dependence, but use them to get started. But fine-tune your system really quickly so that you can sustain this. Utilize the CPT billing codes, the question that the lady asked over there. I think those are just the best right now, and most of the payers now are using those. Same-day medical and behavioral health services, when the payer coordinates, and in both Kansas and Missouri both allow that, so you are safe. North Carolina does too. We changed that 10 years ago. It was a big deal. I mean, I kept, yelling about that one. That was, you were forcing out integration in North Carolina if we couldn't do 2 services on the same day for the Medicaid patient. Partner with other provider organizations. Pursue FQHCs or their lookalike statuses if you need to. You get great federal support when you do that. Negotiate the bundle payments with people like me. And make your practices efficiencies. Again, you've got to manage the no-shows, use internal levels of care. So if I had an internal level of care 30 years ago, my supervisor would have never let me see Michelle for 3 years every week. Because they would have said, what's wrong with you? Why can't you help her to get to a better stage in a shorter period of time? And treat to target models or those step models also help you to do that. So, okay. We got about 15 minutes if you want to take it. So what questions have we generated that you might want to ask? And Eric's going to answer all of them for you one at a time. I'll take the microphone off. What questions?
What is the exact definition of a health home?
The exact definition of a health home? I'm going to use the David Swann version. That would be a comprehensive care system based on a team approach for whole person care. And I think any research you'll look at, it'll have some of those parts in it. That's just, again, my off-the-cuff version, but I think any kind of way you look at it. Now, and I also tend, Ted, I tend to genericize that. There are some distinct people that would say there's a patient-centered medical home that's a little bit of a different twist. There's a general health home. There's the behavioral health, home, and I tend to meld it all together and say what's the same in all of them? It's a team-based, it's whole-person model, and it's comprehensive. So again, whenever you enter into that system, you get all of those options that you need to care for you. And then if we don't provide it internally, we link you up with it externally.
You're not talking about an individual private residence. You're talking about your organization.
Thank you. I'm so sorry. Yes, thank you for clarifying that. Yeah, the word home is not about a residence. Yes, thanks. I've had that question several times, and I just don't think that way. So thanks for asking that question. Yeah, this is the federal definition of a health home, which again, I think the word mall is interesting because we could get that one confused too. But what it describes is picture yourself coming into my home, and when you come into my home, there's a hardwood foyer. So I get you in the front door, and from that foyer, I have a connection to the kitchen, the dining room, the living room, and a bathroom. You can go anywhere you want to go in that house, but what do you need? Do you need the dining room? Do you need the kitchen? Do you need the living room? And you can go off that foyer. So it's a health home that allows you to get to the places that you need within that. Thank you. I'm so glad you asked that, because if anybody else was confused about that, I hadn't done a good job. Yeah, Bobby?
A little bit about accountable care organizations.
Yes.
I know, is that more of a vehicle than actually providing services?
I would say, yeah, it's a vehicle or structure. Picture a very large, the question was about the accountable care organization. This is another tool in the Affordable Care Act that we're seeing running gangbusters nationwide. It is a very large integrated health system. And at its foundation, I've got pictures, if I had all day, I would have probably done a little bit more on that one. But in the pictures of this big accountable care organization, at the foundation, the foot of it, the footing, is hundreds of health homes, as I just defined them, that are all integrated. They might be behavioral health homes with primary health care. They might be primary health care homes with behavioral health care integrated. But the foundation is down at the bottom. They're centric to health homes. And then what you have hospitals, you have specialty clinics like behavioral health or surgical or oncology. You have all of that in a big network. And they work together like the mall version. When the person comes into that health system, you can get the menu of all of those at one time. And the distinctive difference between an accountable care organization and a health home neighborhood, which is kind of what I just described, is the accountable care organization has financial incentives to save money and improve the care. So they save money by shared risk and shared cost savings. So if you and I were members, and Michelle and Eric, all four of us were members of that accountable care organization, and a person comes in and we got a rate, one of those bundled care rates, and we saved money, all four of us share in a bonus of that. Financially, we are rewarded for saving money. It's one of these unique things the government has started to let the money drive the system. And it's possibly one of the first times that we've seen in a long time where money could drive the system in a different direction. There are two vehicles that have come out of the Affordable Care Act on that. And you may already know about this next one. Beginning last October, if you work in a hospital system, beginning last October, you know, Medicare financial penalties for readmissions for Medicare patients took effect. So now, hospitals are now losing disproportionate share. They actually have a little delay in that, but they're going to lose some disproportionate share, and they can be penalized for poor performance. They can be rewarded for higher performance. So there's a financial driver to hospitals through the Affordable Care Act. The other companion is the accountable care organizations, which are centric again in primary health care, but have hospitals in them, where hospitals can obtain a gain in financial savings, and they can share in the financial savings if they're a part of an accountable care organization that delivers better care and saves money. So there's some winners and losing opportunities that were in the Affordable Care Act. You have to do them all to balance them out, and that's what people don't often see. You can pick apart, like I've got 6 friends who are hospital CEOs, and man, they were complaining. Every single one of them lost money beginning October 1st because and I said, what's wrong with this picture? Why shouldn't you be paid well for delivering better outcomes? And why shouldn't you be paid less for not delivering good outcomes? You know, it's really, I mean, I was kind of a believer on let's get better health care out of there. And my mother is one of these people who is Medicare eligible and has been readmitted over and over again for some of these real serious health conditions. And so what could the hospital do? What was happening before October 1 is that you saw a hospital discharge a patient with like CHF and their Medicare, and you wouldn't hear from the hospital again. You know what happens now? When my mom is discharged, she's got 2 nurse care managers today. 2 of them, she's in a hospital right now as we speak. She's got 2 that are planning her discharge into a nursing home on Friday. And they are all over it. They are so deep in that, they cannot stand it because they are also being looked at and evaluated by the hospital as how successful that they can be at keeping people from being readmitted. But see, the olden days is that the hospital got paid more for readmissions because it was ahead of the event. So you see how we were going in a different direction, now we turned it around.
But it's still will have to be stratified because some hospitals might not. They might limit their line of services.
That's correct.
To take care.
Yeah, you asked the level 4 or 5 trauma centers in the nation, who almost always get the worst of the worst, the sickest of the sickest, and the near-death people, and they often die there. You know, I mean, they get to the trauma center, and that's where their life here may end. And so, yeah, there is some differentials I think that are applied to that. But your question about accountable care organizations, I think I answered that by just saying it's the system that has a real true financial driver that helps to change the outcomes.
Well, and the reason I keep seeing ACOs, and then I'm thinking that, unless I'm wrong, MCOs would be more primed to be in that position.
Yes. MCOs can be a part of that too. In fact, we would like to be a part of one of them in my state. We just haven't yet. But if you're an accountable care organization, what would be the best things that you would need to help with behavioral health care? You need good providers in the network, and it would be great if you had a good manager that already has experience in managing for higher quality and lower costs.
And HIE
that can do all that, and all of the data mining that we can do. So, yes, sir.
You brought up a very good point about the HCOs, but what it is happening, I see in the marketplace, is consolidation. The new Affordable Care Act, or whatever act you call it, the definition of hospital was truly inpatient inside the hospital. Now we are changing that from inside the hospital to an episode of care. What is happening is that it is hard that for the hospital to take care of all these episode or continuum. So they are bundling up all the providers' practice wherever they can and say, oh, this is my integrated thing.
Yes.
So we'll see the impact 10 years from now, what it did to us by this methodology.
That's right.
On the surface, it looks great, but are we leaving the rural counties where there is no provider and they have to come all to Kansas City?
Right, because it's so much more effective or efficient to keep it all in one little place. Yeah,
Not
exactly.
very patient-centered to drive 3.5 hours.
No, not very patient-centered at all. But if the hospitals are still at risk for the rural patient in Kansas or Missouri, then there's still something they've got to do about that.
Again, cost benefit.
Yeah.
I can lose on 10 patients and make profit on 100.
That's right. There you go. That's it. Yeah, the sacrificing the few for the many. What other questions? Yes, sir. Yes.
The technology side of this whole scenario.
I sense your frustration.
Dennis, that will be a breakout for folks, for folks who are interested in attending the subsequent ones. David had said the next one really is talking through the financing. We will have one that is really talking about infrastructure, which is everything from the HIE and information sharing to how in the name of God you convert a therapist office to a medical exam room, to a third one that will be sort of on the culture training. How do you talk together? How do you figure out what the real cost is of the 20-minute conversation in the hallway that happened between the psychiatrist and the NP and the therapist, and build that into. So we will have those three, because that, boy, I mean, feel free to ask the question, but that'll be like another 4-hour session without a doubt.
Yeah, that's much more complex than, I think my question or comment maybe more than a question is how to retain some of the flexibility that at least, especially small organizations need. We're a small nonprofit organization compared to some of the bigger folks in the room, and how to be client-centered, fast-paced, coordinated, integrated, and do it at a minimal to no cost on your IT side when the push is, and there are some solutions, I think, so from the IT perspective, I would tell the IT designers, well, make a database that's table-driven, that I have access to the table, and I can change content in some of those fields when the research changes, so that I can keep pace with an evidence-based model that impacts the client. Getting that knowledge into a small nonprofit company that sees the worst of the worst is a huge challenge in this system. And to hold both of those pieces while I'm keeping up with your model is it's a wonderful and terrible challenge at the same time.
It is. It is. Yeah, and I think that was one of my top 10. Is one of those. So, kind of go back to what that gentleman said over there about this. When the hospitals take in all these other practices, essentially that's something they're trying to do too. Those practices are interested in getting larger. They can't do it on their own. So what they're doing is they're merging up with other larger systems to become a part of a larger HIT. So not that you have to do that, but I would encourage you to think, what partners do you need? And could there be a future in your not-for-profit being a part of something very much larger? That's what's happening kind of nationwide. And that's really how the smaller systems are figuring out how they can still keep afloat. So see, I would say we desperately need you. You provide a niche service. It's the worst of the worst. We really can't do it without you. But then you say that you can't do it alone because of the expectations that are there. You really can't make yourself that big, that global, that maybe that impactful. So we figure out the way of how to create a larger system. And see, an accountable care organization really plays into that really well. If you could see yourself as a piece of a bigger structure, doesn't mean that you have to be embedded or even lose your identity, but you have to be affiliated in such a way that when people come into the system, that your menu of services that you offer is available to people when they need it, and quickly and efficiently and effectively. And then the whole IT system makes everything. So that's probably one of the bigger answers. I know it's kind of hard because no one, I mean, this is kind of like capitalism at its finest. Everybody likes to start their own things. Everybody likes to do their own things. And, you know, and I'm from a small town. I got 1,300 people back in my town. I understand that small town interest. Healthcare is one of those things that to achieve some of these goals, it's going to be really hard to do in a small environment. You've got to be bigger. And I think back to the rural areas, yeah, this is really going to be the challenge because we can't, even though maybe financially we see people to cast aside some of the people in rural, we're probably going to, eventually somebody's going to fix that, and we're going to have to get back out there. We're going to have to treat those people. We're going to have to be concerned about those people. And it's too high cost to do it silently. We're going to have to do it as part of something bigger.
Yeah, Cerner doesn't have a division for small nonprofit agencies, and yet they dictate a lot, you know. So there's that balance, right? You know, if you approach somebody at Cerner, you need to do a product for, well, no way, we can't. We don't have anything less than $1 million that you would like to have.
Well, again, Dennis, part of, you know, it's just, I want you to scribble that down because I don't have good scrap paper, but those are the kinds of questions and conversations we can have. I started introducing this today by saying we're different than most of these groups. My hope is that from our workshop, our session on that, we can say, you know what, I mean, I happen to have a couple ties to people at Cerner who, by the way, have worked in mental health, and I could say, you know what, Cerner needs to give back, and maybe a couple of foundations and a couple of, I mean, we're synergistic, we're leveraging, and that's part of what Mark does. It's like, wow, if we could get that done, and you give, you know, X number of thousand, and I give Y, then, you know, we might actually be able to get something functional for it. None of us individually can, but between the leverage and the synergy and partnership, some of these things can work. Speaking of leveraging and synergy and partnership, one of the things that we often leverage is people in the room who pass us slips of paper saying, oh, by the way, there's this cool free webinar coming up Friday. Make sure you announce it. There is a free webinar on the ESPR on Friday, 26th, 11 to 12. You can register it for www.V, capital V, capital A, so Victor, Apple, H, Health, Q, quality.org. If anybody's interested in that, I'm aware folks have been sitting for a very long time. I'm also aware David has a plane to make, but not immediately. I would thank the foundations, thank Mark, thank members of the planning team for this event, and all of you to come out. I bet David will stand around for a few minutes for anybody who wants to privately pick his brain.
Will do. Thank you all. Great day.
I can't be. I've got one. It's right here. www.
You never did get the chat, did you? All right.
Did you speak at policy just policies, and it was about just policies?
Yeah.
They had a section on it.
I may have, because I do that stuff a lot. Yeah. Well, thank you for thinking about me. I did. So, hey there.
Hi.
I'm David. Nice to see you. Nice to meet you. Nice to meet you. Yes,
I've been there on myself and on other people. It's just
yeah, they don't quite understand how much they need to do.
Exactly. So what I've kind of got to meeting on is allow me. I think so. So, oh yeah.
Look for, glad to meet you.
Great to meet you.
So this is what I did in 1987. And the problem.
Oh, evaluations, if you will set your purple evaluations up at the front here, we would appreciate it. I knew I forgot something. Darn it.
The night.
I actually did it in India. And I did it on Wednesdays. And I I found that the kids are retain nearly 100%. And voice serves, I like it when I can hear it.
We're gonna have that experience when we get
Yeah, I think so.
So it was a really big learning experience for us, but
Thank you so much. Take care.
See
Take
you next
care.
time.
so just keep organizing and offer the opportunity to engage with things around, you know, I think I can help you with that. Or you hear me talking about a problem or challenge, and then so you think about how to do it. Maybe our supply chain is we're hanging fruit on there, but even on somebody like, you know, Mark, right?
Sometimes it just right, so
I'm sure we will see each other.
John 10
I don't see them talking about this.
I don't know, and I think it's skewed information because I've been just working
Spit to my office from here, just across the line. He served both sides of the street. Yeah, it's good stuff. It's the one good thing, one little tiny
But
thing.
outside of that, I really don't know much else. But it is in Kansas. Here's something that the three managed care organizations are moving in this direction.
Okay, good.
So they're being asked to turn around.
I know you're having a very strange conversation over the last speaker. I'm like, what's he doing about me?
Good job.
So those three behavioral health managed care organizations are
Yeah. Do you recycle paper or anything?
Yeah, we have.
Okay.
Do we have more of these?
I'm trying to sort as I pull. Probably not as many. I should have shouted about that at the front.
Good job, Tracy.
Oh, thank you.
I just thought I was thinking, I'll shake your hand.
David did it all.
I'm sorry.
So I think it's on its way, but I can't tell you
All right. Well, thank you very, very much. It was excellent.
Thank you very much.
Information. I appreciate it.
I'm so glad you got it.
Thank you.
Yeah, all right. It's a good day. So, again.
Excellent. Very good presentation.
Very
I'm
much.
so excited about
Jazzed up.
things that people who work with the field level from administration doesn't spans. It's centered somewhere. We know the words, but how to explain.
Yeah, we did exactly what she said. It doesn't have the same traction as the does. It does and I think that's the thing is that hopefully what we did today is we created initiatives. One, wherever y'all go, when you plant seeds, where
Now I have a couple of aspects. If you can share your slide, is it possible?
I was not surprised to be impressed, but I was
my
impressed.
other missionaries who are there and
I can email that.
I was going to say, there's spares too.
this is where it is going. This is I want. We are CMS. The next scope of work of CMS is integration of mental health and behavioral. We know